And in the fifth session, the Indonesia G20 presidency will launch a call to action on financing for TB response. All right, ladies and gentlemen, let's start our third session with the topic of development of airborne infection defense approach. May I have your applause for all the speakers for the third session. The first speaker, Suvanand Sahu, Stop TB Partnership, Vidya Krishnan from Journalist and Author, Erlina Burhan as Pulmonologist and Board of Stop TB Partnership Indonesia. And the third session will be conducted by the Director of Center for Global Health Science and Security, Georgetown University, Rebecca Katz. Before we begin, distinguished speakers, I would like to remind you that when the time is up, you will slightly hear a gamelan instrument just to wrap up your presentation. Thank you very much for your kind attention, and dear Rebecca, the floor is yours.
Hello, and I'd say good morning, good evening. It's approximately midnight here in Washington, D.C., so I'm delighted to be joining all of you from all over the world. This is a critical discussion, and I know our time is limited, so I'm going to do my best to keep my opening remarks quite short so we have sufficient time to hear from all of our distinguished speakers. I know it's been said before, but I'd like to say it again. You know, the pandemic has clearly and appropriately captured global attention, but we know that response has meant a diversion of resources and attention from other health challenges, including tuberculosis. We also know that we live in a world of limited resources, and as those of us who have worked in public health our whole lives unfortunately know way too well, there are never enough resources. And we know that for a myriad of reasons, tuberculosis just doesn't often seem to capture the attention of decision makers given the incredible burden of disease. So knowing all of this, how do we move forward in a resource-constrained world? And how do we take what we've learned from pandemic response and apply it to tuberculosis? And then how do we look closely at the programs and assets that we have for tuberculosis and ensure that they are not siloed, and in fact are integrated into core competencies and capacities for pandemic preparedness and response? I think we have an opportunity to rethink and reframe. We can leverage knowledge and assets to not only strengthen our response to TB, but also protect populations from future airborne infections. How do we build on capacities for detecting and managing microbial resistance to strengthen community engagement and early warning? Can we make sure that every effort in TB is checked against how it can support broader population health, lung health, and PPR capacity? And can building diagnostic capacity for TB, and particularly drug-resistant TB, be more fully integrated into a health system so that overall laboratory capacity is strengthened? And can we leverage treatment successes and patient engagement to improve broader healthcare services? And then can we learn from the enablers to support TB patients in isolation and extend those lessons to quarantine and isolation measures used in a pandemic? And can we make sure that every effort to build PPR capacity is checked against how it can support the fight against those existing population health challenges like TB? And I know from my own work that there are many opportunities to do better. We've studied how TB control officers in the United States found isolated and supported patients. We conducted these studies years ago, thinking about TB isolation as a proxy for how health departments might handle quarantine in a pandemic. But it's clear that many of the lessons that could have been translated to these wide-scale quarantine and isolation efforts were not. We've also spent a lot of time mapping budgetary lines in tuberculosis to PPR activities, and then mapping the reverse PPR activities to TB. And there are, to be sure, many overlaps, but still, again, much to be learned. So we're at a pivotal moment where the world has an opportunity to strengthen and fund a more robust global health security architecture, but also to better prepare for the next threat, with airborne infections and AMR being at the very top of that threat list. And hopefully to break down some of the walls that have been erected and better integrate horizontal and vertical programs. But we need to do so in a way that strengthens health systems, builds pandemic preparedness and response capabilities, but also addresses the unique approaches required to address these major existing population health threats, like tuberculosis. So as mentioned, the title of this session is Development of Airborne Infection Defense Approach. So over the next 50 minutes, we'll hear from a truly impressive lineup of experts. Now, the list that I have for this session, is we start with Dr. Wang Hesheng, the Vice Minister of National Health Commission of China and Commissioner of the National Disease Prevention and Control, to share experiences from China on both TB and the COVID-19 response. We'll then turn to Suvanand Sahu, the Deputy Executive Director of Stop TB Partnership, on how to leverage health security approaches to accelerate efforts to end TB. Our third speaker will be Vidya Krishnan, the author of, and I'm going to hold it up for all to see, the Phantom Plague and How Tuberculosis Shaped History. And finally, we'll hear from Dr. Erlina Burhan, a pulmonologist and a board member of the Stop TB Partnership. And the ask for all of our speakers is to conclude your remarks with specific strategic recommendations to the G20 Health Working Group on how TB should be addressed in both the ministerial and head of state's declaration. And if you have any takeaways for TB financing, that could be and should be addressed in subsequent high-level meetings. So with that, I would like to turn it over to Dr. Wang Hesheng, as I have you as first, but again, I'm not 100% sure you are online, so maybe a moment's pause to see. Without seeing the speaker, why don't we move on directly to Suvanand Sahu? And if I am missing anybody, then we can always come back around in the speaker list. Sir, over to you.
Thank you, Rebecca. Let me share my screen. Just a moment. Excellencies and distinguished participants, good morning, good afternoon, or good evening, depending on where you are connecting from. I am connecting from Geneva, and it is 6 o'clock in the morning. In the next few minutes, I will talk on how we can invest on an airborne infection defense approach with a dual purpose of filling in the gaps in funding for TB, as well as to prepare the world against future pandemics. In this meeting and elsewhere, much has been talked about the impact of COVID-19 pandemic on TB. Let me highlight 2 points relevant to the topic of my talk. First, I want to highlight the fact that in many high TB burden countries, TB programs were launchpads for COVID-19 responses. It was an obvious choice to look towards TB when confronted with a new respiratory killer infection. TB programs had the expertise on testing, contact tracing, respiratory care, masking, ventilation, ultraviolet lights, etc. TB programs, human resources and infrastructure were repurposed to include COVID-19. This was a good contribution of TB programs. The second point I wanted to highlight is the question, what went wrong and why? There was a huge setback to TB services. Service delivery and access to TB diagnosis and treatment declined, leading to an 18% overall drop in 2020. Reversing a good trend in previous years, as you can see in the graph on the slide. The reasons could be multiple, but one common and clear reason was that historically, TB programs were underfunded, overstretched, and did not have the surge capacity to deal with both TB during lockdowns and also a new infection like COVID. If TB programs were well funded with good surge capacity, then they would have contributed more to the COVID response, and TB services would not have been disrupted at the same time. Stop TB Partnership is currently developing the new global plan to end TB. And yesterday in this forum, Phaahla Fujiwara presented the resource needs estimates from the global plan. It is clear that currently available funding for TB needs to be quadrupled 4 times. Inclusion of TB in pandemic preparedness and response is one of the ways to increase funding for TB. Funding that could serve the dual purpose of fighting TB as well as getting prepared for future pandemics. Let me talk about why TB needs to be integrated into future PPR initiatives. Very likely that the next pandemic will be an airborne infection, particularly if it is of the same magnitude as we saw for COVID-19. TB is a disease that will stay in between pandemics. It will outlive the COVID-19 pandemic, very likely. Adding investments to strengthen infrastructure and capacity of TB programs will help in developing surge capacity to fight new airborne infections. In between pandemics, monitoring progress in TB could serve as a marker of the state of preparedness to fight new airborne infections. So integrating TB into PPR is a smart way of investing on TB and preparing for future pandemics. Many people have also mentioned that PPR should include new as well as old infectious diseases, and TB fits very well in this context as an old infectious disease which has claimed more lives than any other. To take concrete steps towards integrating TB into PPR, we suggest an airborne infection defense approach. Let me pause for a while and let me say something here for us to think about. The world today has invested heavily on airborne missile defense systems for protection of people, but not yet invested on an airborne infection defense system that could protect people against airborne killer microorganisms. The COVID pandemic is a wake-up call to do so. Now, what is the airborne infection defense approach? The objective is to develop the capacity of the world to defend against deadly respiratory infections. It must be built on experience and expertise of country TB responses. High TB burden countries have years of experience on this, so there is no need to reinvent the wheel. Countries could establish airborne infection defense platforms, and these platforms could be networked for learning and sharing of lessons. We suggest 8 focus areas for this airborne infection defense approach, ranging from testing, tracing, airborne infection control to respiratory care, surveillance, community engagement, digital health tools, and research into new vaccines, diagnostics, and therapeutics. And let me elaborate a few of them, not all, because of lack of time here. First, on the screening, testing, and contact tracing. Investing on multiplex testing technology with a dual purpose for TB as well as other respiratory infections. We saw during the COVID pandemic, many TB high burden countries did what was called as bidirectional testing, simultaneously testing people for TB and COVID. This could be done for multiple pathogens, especially respiratory origin. genome sequencing for TB and respiratory pathogen strains that have potential for escaping therapeutics or vaccine impact. Modern ultra-portable AI-enabled X-ray systems, imaging systems for lungs that could detect multiple diseases. Investments into laboratories, mobile diagnostic vans, imaging lab information systems, and establishing a cadre of human resources for contact tracing. In all these, it is also important to plan for surge capacity for infection outbreaks in the future. Let me talk about one more area out of the 8 that I presented, which is also important and relevant here. In the area of airborne infection prevention and control, this has been a component of TB programs for decades. Many people who work on TB know about it, but it is missing, I must emphasize, missing from the general health system, congregate indoor public spaces and workplaces. It is time to change this to prepare for the next airborne pandemic. Investments on universal airborne infection prevention and control across health system, congregate indoor settings and workplaces is a smart thing to do that will help fight TB and other airborne infections and could avoid shutdown of workplaces and economic activities during future pandemics. There are all the different areas, but I will not go into the details of it, but each area, there are some things we can do concretely for helping the TB response, but also preparing the world for the next pandemic. Then let me now move on to global health security and TB. Consider this, an airborne infection with capacity to spread. One can infect 15 others. It can spread across countries, does not respect international boundaries. Deadly infection, 15% mortality, as high as 15%, 10 million cases each year, 1.5 million deaths. This mortality goes up to 50% or more if untreated. Drug-resistant variants of the disease, some variants are very difficult to treat, we know, or virtually untreatable with very high mortality. And we have seen historically that socioeconomic downturns and displaced populations have always flared up TB in many parts of the world. If this is not, if this is not enough to consider TB as a global health security threat, then what can be considered as a threat? Therefore, TB elimination should be a priority for global health security. Now, let me come to my last slide that I wanted to summarize a few things for us to think about as recommendations for this G20 group. The G20 must recognize TB as a global health security threat and include TB elimination in pandemic preparedness and response. So far, we haven't seen that happen, but unless it is done very consciously, this will not happen. G20 Health Working Group should, based on this TB event, recommend increased investments on ending TB, highlight that a large part of these additional investments on TB can come from finances committed to PPR. Note that the proposed airborne infection defense approach can be a concrete way forward for dual-purpose investments in TB and PPR. And finally, the T20 group of G20 should create opportunities to discuss further the technical aspects of the airborne infection defense approach. Thank you for the time and attention, and I hand over back to the chair. Thank you.
Thank you so much for that. I don't know if we will have time to come back at towards the end of the session, but I am very appreciative of the specific recommendations for particularly the notion of including TB elimination in PPR. I would also, just to highlight the fact that you did note that we need 4 times the amount of financing as we currently have. and greatly appreciate the clarity in the 8 focus areas of the system of AIDA, I guess we'll call it. So again, thank you so much for that clear and really important presentation. We're going to change the schedule around a little bit, and if she is ready, I'd like to go to Dr. Erlina next.
Thank you, Rebecca. Please, the committee, share my screen, helping me sharing my screen, please. Yeah, my name is Erlina Burhan. I'm a pulmonologist and also a board member of TB Partnership Indonesia, and also the head of COPI TB. COPI TB is the Indonesian Coalition Professional Organization for TB. Okay, first slide, please. Can my slide be in the center? Committee? Is still Rebecca in the screen, in the center, not my slide?
Let's get me off the center and let's get the slide in, if possible.
Okay. So, I would like to have this, the committee can do something about this. Because then, if we keep this way, I'm afraid that the audience cannot really see. Can you see Rebecca on my screen?
I think if I pin the box, I'll be able to see. But I'm hoping the team can actually enlarge it.
Okay, please committee help us here, because I send the slide to you and you can process.
Yes, the slide is currently available. It's just not being highlighted.
Sorry to interrupt. I've been able to drag down the slide and I can see it. So I think if everybody just takes it off their pin bar and just clicks on it, we should be able to see the slide, Ibu Erlina.
Okay. Okay, thank you then. First, I would like to say what COVID-19 pandemic did to my TB patient. Let me tell you, they did not show up to the clinic or to the hospital, even though they have TB symptom. They did not continue the drug, even though the drug is out of the stock at home. And also there is a less ability to seek care due to movement restriction that's allowed by the government due to TB. So this condition will lead to disruption of TB diagnostic and treatment services during COVID-19. And what happened next? Because of this, there will be increasing drug-resistant cases, will be increasing mortality, will be increasing transmission, and what happened to our TB elimination target in 2030. We cannot say, no, we can reach it. Actually, we have to invest. We have to switch everything to invest. Invest the money, invest the time, invest your expertise in order still to the track of TB elimination target. Next slide. The other thing is that why the patients are afraid coming to the hospital, because we all know that there is a similarity of the symptom of TB and COVID. In COVID, there is a fever, yet also in TB, but the difference is fever in COVID more than 38 degree of Celsius, while for TB is less than 38 degree of Celsius. There is also coughing but the coughing in COVID is dry cough, while in the TB is coughing with sputum. And the other similarity is during Delta is the short of breathness. That is also found in TB, but the difference is the short of breathness in COVID can happen very easily and acute, but in TB, short of breathness usually takes some time. And also the chest X-ray, it is similarity. You can see the feature of pneumonia, and the same thing in also for TB, but except for TB, the location is in the apex. Next slide. So this is the situation in Indonesia that the pandemic disruption of TB control management, decrease in government funding for TB, lower quality of case and treatment because a lot of clinic or also outpatient are closed because they are shifting for the COVID services, and also the inpatient facility in the hospital then also shifting for the COVID isolation. So this condition decrease in TB case detection and also lowering activities in monitoring, evaluation, and surveillance. A lot of TB healthcare worker also assigned for COVID, and then they do more for COVID than for TB. Next slide. Yeah. So this number can tell us, numbers speak. You see that the TB notification in Indonesia from 2018 until 2021 is slowly decreasing. The same thing with the TB treatment coverage. It is also decreasing, declining, and this is for me as a clinician, I'm very, very sad with this situation, knowing the coverage is very low and also the success rate also low. It's not, it's lower than the target. So what happened next? If the patient did not finish the treatment, so we will have a decreasing number of drug-resistant TB, and also they will remain as a source of transmission. Next slide. So this is me thinking out loud as Ed Sheeran, the song of Ed Sheeran. Seeing the COVID-19 pandemic, I see the silver lining that actually can be benefit for TB. So the implementation of 3T, tracing, testing, and treatment, was actually belong to TB program, but was not implemented very optimal like what they do in COVID. So this is the silver lining that 3T should be done also properly for TB. Testing, tracing, and treatment, and also when you find the cases, treat them, and even treating also the latent TB infection. To do this, collaboration is something that we have to do. And this is really applied and implemented in COVID management. I've never seen this collaboration in TB before. Yeah, people say it in COVID, no one safe until everyone is safe. So that's why everyone trying to invest everything to reach this situation, but not in TB. And also vaccine. The outbreak is 2020 and the vaccine available in 2021. Less than 1 year, we got a COVID-19 vaccine. Does not happen in TB. TB vaccine BCG was launched in 1928, and now after 94 years, we don't see new TB vaccine anymore. I know that 12 platform of TB vaccine now is under clinical trial, but very, very slow, 92 years to have this situation. But for COVID, 1 year only. This is collaboration that not happen in TB. Next slide. So tracing in COVID is case finding in TB, active case finding, and also systematic screening household contact. And this is done by the help of local government, not only a healthcare worker. This is what I say, that collaboration. Yeah? And community engagement with active leadership of local government is very critical. And that's happened in COVID, but not in TB. Sahu, we have been talking about this in PPM since long time ago, but the implementation is very weak. I'm sometimes frustrated, but I thank to COVID. I thank to COVID-19 because there is a silver lining that we can use for TB. And one more thing, the tracing using digital technology is being applied for COVID. Again, COVID and COVID. In Indonesia, there's a Peduli Lindungi platform, that dashboard, that you can see how many cases in daily basis, how many are cured, how many are died. There is, we can see every day in platform digital technology. And there is also a digital technology to do a tracing. It's called si jejak or silacak. That's for COVID. Investments are very huge for COVID, but not for TB. And you see the difference. COVID now is declining, and TB stay the same. Indonesia have 824,000 new cases in a year, and I don't know whether it will decline as big as COVID. Next slide. And for this testing, our gene expert that used to diagnose TB during the COVID was used to diagnose COVID. Okay, that's why also we have a very low number of detection, yeah. And then I think we need to also update socialized and national TB guideline. There are TB guidelines, there are SOP, there are other guidelines for TB, but the implementation is very weak again. And also for the treatment, as I mentioned, there is a problem of patient coming to the clinic and hospital to get the drug, or to continue the drug until the end of the treatment. That's many of the cases, they were not in place. So the impact is the increasing number of drug resistant. Yeah. So again, for this drug resistant, for the treatment, the guideline need to be updated and also socialized. Especially right now, we have all oral treatment, short and individualized, and even we have a very short for pre-XDR and XDR, such as BPAL. Then this is need to be also being used in many places. Next slide. Preventive treatment. This is not really something many stakeholders not focusing. We still focus in treating the active cases, but when we still busy with treating active cases, we forgot that latent TB is going up also. So this is really tiring. So please now focus also on preventive treatment. So diagnosed latent TB is also one that we need to put an intention also. And to do so, again, collaboration. Local government, professional organization, and NTP and other people, everyone should in line with what is the target of the country, of the global situation. Next slide. So, everyone knows that what TB Day team is invest to NTB and save life. I want to ask anyone to invest. You do not need to invest only money. Invest your expertise, invest your time, invest whatever you can do. And you know, in this aspect, we need also to put more investment in erasing stigma. In COVID, people will upload in their Instagram or Facebook, "Hey guys, I'm having COVID," but no one would like to do so for TB. They hide their status, but not for COVID. So our target also to erase stigma. That's really important. Collaboration and multi-sectoral action. That's the first one. So collaboration and erasing stigma, and the rest will go just follow. Next slide. This is lesson learned from COVID-19 pandemic management. In Indonesia, even from the president, our national health system, innovation stakeholder, businessmen, government, religious and cultural society leader and community, educational institution, everyone, every health sector collaborate to manage, to find and manage and treat COVID. If this collaboration also apply for TB, it will be wonderful. We can reach TB elimination easily in 2030. And one more time, health protocol in COVID. Wearing masks as I'm wearing now because I'm in the hospital, washing hand, keeping distance. That's also suitable for TB and other respiratory infectious disease prevention, such as for SARS, MERS, Ebola, Zika, and future global pandemic caused by novel infectious agent. Next slide. And this is what we don't really put attention also. Utilize the digital platform. This is used in COVID-19. Yeah, they have like a platform that can do a contact tracing to identify the cases and everything. But we don't do that for TB. We now do a digital platform for, let's say, treatment observer by VOT, video observer treatment. But I think digital platform need to be also used for TB. Next slide. So how to prevent future pandemic? 1. Public health control. Strict control and improvement in hygiene measurement, like a health protocol. And then government and non-governmental need to focus on preparing healthcare infrastructure and viral surveillance to predict the next outbreak. And do not forget that biopharmaceutical industry is also play an important role. They should focusing on competitive innovation, maybe for the diagnostic tool for TB, for vaccine and everything. And the last, academia and the pharmaceutical industry must focus on research, drug discovery. We have not so many options for a drug in TB. Yeah, yes, of course we have a few new drugs such as bedaquiline, delamanid, and pretomanid, but actually research for drug recovery is still needed. And also for antiviral for other viral infection therapy. Next slide. Okay, this is me saying, let's make noises. Why? Because TB, I think, is very low profile, old-fashioned. The people who are working for TB are very, very gentlemen, ladies-like. Yeah, they don't do making noises. So I think if we continue to maintain business as usual, then we will not be able to achieve TB elimination target by 2030. So please invest and make noises. This is Erlina Burhan saying. Next slide. One more thing. We celebrate World TB Day only in March 24. But for me, TB is every day. And TB is everyone business. Thank you. Over to you, Rebecca.
Erlina, thank you so much for that. We should all make noise is what we can take away. I think it's so critical to have the perspective from clinicians who are treating patients and to be able to speak to the implementation of tracking, testing, and treatment and collaboration, but mostly make noise. So thank you so much. I believe we will now turn to Vidya Krishnan. Hopefully you can hear and see us. And I'm not sure you were with us before, but I did hold up the book. So at some point I'll have to get you to sign it for me. Please, the floor is yours, and we look forward to hearing from you.
Thank you for having me over. Good morning from India. I have many things to say and little time to say it, and so I'm going to dive right in. When I was invited, I was told that the session was about enabling a pandemic-resistant world from pathogens that are for sure lurking around the corner. Tuberculosis, particularly drug-resistant tuberculosis, is one of those pathogens. So here I am bringing my book, Phantom Plague, to readers, politicians, scientists, policymakers, and patients who I am privileged to address today. In these plague years, I find myself thinking more and more about the relationship between writers and readers who happen to be professors and scientists and policymakers, and more importantly, patients. And inevitably, I end up at this analogy. Regardless of the kind of infectious disease, it is as though patients have been rounded up and loaded in two fleets, a big one and a small one. The small fleet has reached a destination that the rest of us can only aspire to, the post-pandemic world. The larger caravan, one with more people and by extension more sick people and more poor people and more vulnerable people, that convoy is currently lost in the shadows. A cursory survey of who gets to be on which caravan reveals a predictable architecture of unfairness, stacking the odds against racial, gender, religious, as well as caste minorities. In my country, lower caste communities have disproportionate health deficits, much the same way as African American communities or refugees or immigrants do in the UK or EU. In that part of the world, the small convoy of triple vaccinated people has reached a glittering destination where it lives and prospers. This is because 80% of COVID vaccines were administered in 10 richest countries in the last year, leaving 3 billion people, half of the world's population, waiting for their first doses. It's even more tragic that this is being done without extending the courtesy to Black and brown minorities within the global north. The well-being of this smaller fleet, I will posit, is being subsidized by the medical superstructures of our world at the cost of Black and brown communities, revealing the utter illogic of, as well as the root of the global health insecurities we now face. All of this brings me to the foundational flaw from which other flaws in pandemic response emerge, the TRIPS agreement. After 17 months, a compromise text was recently leaked. It's hard to miss that the compromise text is a compromise of an original compromise of the actual idea, equality. Today, everything the critics predicted about TRIPS waiver has come true with an eerie vengeance. Vaccines are being made in India at a fraction of a cost, but being denied to the poorest amongst us using costs as an excuse. Every day, I'm taken aback by media reports that think asking for IP waivers is equal to freeloading or stealing from the mind of the inventors. When Black and brown nations want to purchase technologies, the goalpost is moved, questioning the manufacturing capacity of the very nations that manufacture everything from t-shirts to iPhones to, yes, vaccines, that India provides to organizations like UNICEF and WHO at a fraction of the cost. This concern about manufacturing quality implies that Big Pharma is on a mission to get safe medicines to every part of the world. In the middle of a raging pandemic, we are being asked to believe that locking medicines in intellectual property is for our own safety. I find it difficult to reconcile with this peculiar definition of concern. The compromise is that the powerful have decided not to compromise. So here we are, 18 months of negotiations later, consultants, pharma companies, politicians, and policymakers, that is, people with power to take swift decisions, have been mulling over the subject with spectatorial passivity, as if it's a rare and theoretical matter, one that must not set a precedent. In truth, this is not rare for us in the global south, and for patients who are condemned to die from treatable illnesses, plague after plague, because life-saving remedies remain locked in patent monopolies. No one who lived in Delhi in those terrifying months of the second wave, as the city ran out of beds and ambulances and medical oxygen, and then ran out of wood for funeral pyre and fabric for shrouds, will consider this a theoretical matter either. This was a vaccine preventable illness devastating India's national capital. What I now see is a vulgar focus on commerce as the most precious asset of our nations, the health of our people, is being sacrificed at the altar of shareholder supremacy. This is forcing us to live with a deadly but preventable disease simply because it is not profitable to offer newer therapies. In TB, bedaquiline and delamanid remain locked in patent monopolies much the same way as mRNA vaccines remain. Both these diseases are preventable in the global north and deadly in the south. As a writer, I dwell on words a lot. In the 17 months, the powers that be have spent mulling over TRIPS waiver, I have been mulling over words like negotiation, flexibility, and compromise. The words imply that the global north is open to imagining a new world, one in which lives in the global south are precious as well as equal. After 18 months, we now know that power does not negotiate or compromise or extend flexibilities. I also know that one doesn't have to operate with great malice to inflict harm. The refusal to act urgently and with empathy does the same. The failure to arrive at a proportionate response on TRIPS is a failure of our moral imagination, an inability to see the world other than in terms that have been set out to us. The TRIPS law, I will argue, is pharmaceutical decadence disguised in legalese. Every time the question of rights is raised, it is answered with charity, the opium of the rich, which has been consecrated as an ideology within the structures of Global South. This myopic approach is leading us straight into the fifth wave, where once again Black and brown nations will be disproportionately affected. Is it not fair, or is at least theoretically possible, that the political climate demand that we set aside old structures and build new ones? I believe such a time is upon us. The most immediate need is to stop the current pandemic, which cannot be done without a total TRIPS waiver on intellectual property for drugs, diagnostics, as well as vaccines. Equally important is for us to acknowledge the medical apartheid, which is unguarded by an illogical system of decision-making at WTO, which builds consensus when there are rules that allow member states to vote on issues. This has never been done, and maybe it's time to have a voting system at WTO giving developing nations an equal say in decisions. In Phantom Plague, I dwell on IP laws quite a bit, translating numbers and graphs and drug resistance data into stories of real people with real homes and real lives. Stories about what it is like to lose a child or a lung or your dignity to an invisible force that you cannot see or hate or reason with. We are facing an existential crisis. At this historic juncture, bargaining for our right to health with pharmaceutical multinationals is equal to building a pandemic-resistant future on quicksand. While the global north, boosted and impatient, has an irrational longing to go back to the past, a world before pestilence, or else perhaps fast forward to one without it, the rest of us are composing ourselves and each other as we wait for vaccines to arrive. But pandemics do not end simply because people have irrational longings. Since the beginning of the pandemic, the words "no one is safe until everyone is" has been uttered so many times that it has been drained of its meaning, the way words do when they're repeated too often. Yet in year 3, we go on repeating it mechanically, trying through these dead words to convey some notion of the ordeal that's being inflicted on us. If we found a spot in the smaller fleet, I understand the instinct to not question status quo, but I am here to tell you that to hold back vaccines and life-saving treatment is terrible and violent and immoral. This is not an economic conversation. This situation should force upon us some uncomfortable question about the moral core of our values, the vision for our future, and the legitimacy of institutions and very crucially, our responsibility as global citizens, for that's what we are. Whether we like it or not, the world is one family. The pathogens see that, and we should too.
Thank you so much. I am cognizant of time and recognizing that we are, even with missing one of our speakers this session, we are still a little bit over, but I just wanted to thank you for bringing up and discussing these issues of vaccine. I don't have the words of that the writer has, but the issues of vaccine inequity and access to medicine, IPR, and for the current pandemic, as well as the implications for access to care for tuberculosis. So with that, I want to thank all of the speakers for your contributions today, and our thanks to the audience and as well as the online participants for coming to this session. We hope it has been helpful, it's been interesting to all of you, and we're just deeply thankful for the opportunity to be having this conversation today, well, this evening for me. So with that, I'll end the session. I realize we're a few minutes over, but hopefully we are not too disruptive to the schedule. And back over to the organizers. Thank you all for everything today.
Thank you. Applause, please, ladies and gentlemen. Thank you very much once again to our distinguished chair and speakers for the section. Ladies and gentlemen, we have listened to the third session. And before we start the next session, ladies and gentlemen, we will have lunch break. And we'll be going back here at 1 p.m. After the lunch break, we're going to continue our agenda to the fourth session about financing to end tuberculosis in 2030, how the G20-led success will look. So ladies and gentlemen, now it's time for lunch break. Please enjoy the lunch, and I'll see you again at 1 p.m. in this room. Thank you very much.
Bang.
Wow, udah pada kumpul.
Iya dong.
Iya dong.
Ayo. Kak, gimana kalau kita minum dulu?
Ayo, boleh.
Sambil nyanyi. Cheers dulu dong.
Cheers.
Cheers.
Apa kabarnya, Bang? Ya, begitulah, Mayan.
Yaudah, kita nyanyi bareng ya?
Ayo. Bentar. Gimana kalau kita main truth order aja?
Ayo, gas.
Lebih seru kan? Aku putar botolnya ya. Ya,
Om kena.
Ayo kena. Ibu kena.
Ibu kan ikutan.
Ayo lagi.
Ya, kakak kena tuh. Ya, kakak kena tuh. Kakak kenapa sih? Kok dari tadi batuk-batuk terus?
Nggak tahu nih udah 2 minggu kayak gini terus.
Wah, harus segera cek ke dokter, Bang.
Iya tuh bener.
Iya nih.
Setiap orang berpeluang yang sama mengalami TBC. Yang perlu disadari, risiko kita untuk terpapar cukup besar. Semakin segera cek, semakin cepat sembuh. Ingat 14 satu cek TBC. Jika 14 hari batuk tak reda, satu solusi, cek dokter segera. Ayo, temukan TBC, obati sampai sembuh. 14 hari batuk tak reda, satu solusi, cek dokter segera. Segera cek website di 141.stoptbindonesia.org kami.
diseases that knows no borders. We are dealing with diseases that knows no borders.
আমার নাম মোহাম্মদ আসাদ মিয়া। আমার জীবনে সবচেয়ে গুরুত্বপূর্ণ আমার পরিবার। আমি একজন স্বামী, আমি একজন ছেলে, আমি একজন বাবুর্চি। আমি যক্ষ্মা থেকে সুস্থতা লাভ করছি। বেশ কয়েক মাস আগে আমার মা খুব অসুস্থ হয়ে পড়ছিল। তখন আমার পাশে যে ক্লিনিক আছে, ক্লিনিকে নিয়ে গেলাম। ডাক্তার কিছু টেস্ট দিল। তখন এই টেস্টগুলো ছিল খুবই ব্যয়বহুল। তো ওই মুহূর্তে আমার কাছে কোনো টাকা পয়সা ছিল না। তো আমার শেষ একটা সম্বল ছিল চটপটির গাড়ি। সেই গাড়িটা আমি বিক্রি করে দিলাম। বিক্রি করে দিয়ে আমার মার ওই টেস্টগুলো আমি করালাম। তো ব্লাড টেস্ট করানোর পর বললো যে ব্লাড টেস্টে কোনো সমস্যা নেই, আপনার আমাকে সাময়িক এই ওষুধগুলো খাওয়ালে ঠিক হয়ে যাবে। তা 3-4 দিন খাওয়ালাম, খাওয়ানোর পরও কমলো না। দেওয়ার পরে তারপর সুস্থতা শুধু পিছনে যাইতে চাই। ওর মধ্যে আবার করোনা চলতেছে, তখন আমার সম্পূর্ণ ইনকাম সোর্সই বন্ধ হয়ে গেল। এই মুহূর্তে আমার তেমন একটা চিকিৎসা করতে পারি নাই। আমার শেষ সময় যে ব্যবসাটা ছিল সেটা আমার হাতছাড়া হয়ে গেল। আমি সব দিকে অন্ধকারে গেলাম। এর মধ্যে নিজের শরীর অবস্থাও তেমন একটা ভালো না। নিজে খুব অসুস্থ বোধ করতেছি। বুকে ব্যথা, সর্দি, কাশি। আমার অবস্থা ওই সময় যে অবস্থা ছিল, মানে খুবই কষ্ট। যেটা আমি বলতেছি এটা আমি বাস্তবে অনেক ইচ্ছে বেশি কষ্ট করছি বাস্তবে ওই মুহূর্তে। তখন আমার এই অবস্থা দেখে আমার পাশের একজন আমাকে এসে বললো যে আপনি ব্র্যাকের একটা আপা আছে। তখন উনি আমাকে ওনার সাথে যোগাযোগ করিয়ে দিল। টিবি ক্লিনিকে নাম ওনার শাহনাজ আপা। কফ পরীক্ষা করালো, এক্সরে করালো। করানোর পরে সেখানে আমাকে বললো যে আপনার তো যক্ষ্মা হয়েছে। তবে আমার যে সমস্যাগুলো ছিল সেই সমস্যাগুলো শাহনাজ আপা দেখে বললো আপনি যে কোনো একটা ডাক্তারে দেখান। তখন ডাক্তারে দেখালাম। দেখানোর পর ওই ডাক্তার বললো যে আপনার আমার যক্ষ্মা হয়েছে এবং ফ্রিলি ওষুধগুলো খাই। প্রতিদিন 3টা করে ওষুধ আমাদের খাওয়াতো 6 মাস। 6 মাস একটানা খাওয়ার পর এখন আমরা সুস্থ হয়েছি। যেহেতু এখন আমি এবং আমার মা আমরা দুজনেই সুস্থ, এখন আমার মনে অনেক সাহস আছে, শক্তি আছে। আমার একটা দোকান আছে, চটপটি দোকান। আমি মনের দিক দিয়ে এখন অনেক খুশি। আমি এখন সুস্থ, এর বেশি কিছু না। যে কোনো মূল্যে আমি লড়াই করতে এখন প্রস্তুত। আমার পরিবারের জন্য, আমার মায়ের জন্য, আমার নিজের সুস্থতার জন্য।
The doctor said that there's no need to worry because tuberculosis is treatable and curable. I just need to take my medicines and eat well. But tuberculosis makes me feel lost and alone. I miss my friends so much.
Seryoso ba yan?
Oh no. Uy,
Nico.
Nico. Oh, Nico.
Am I strong enough to overcome this? But I was never alone in my journey. I was so afraid I would lose my friends, my love. But I was wrong. They invested their love, care, and support for me. I was so happy to hear that I was free of tuberculosis. The doctor and the health workers helped me live. The medicines and treatment saved me. But most importantly, the hope and love my family and friends gave me helped me beat tuberculosis. My experience has inspired me. I want to invest in ending TB by supporting others in their journey of healing.
Behold, the beauty that is Indonesia. Mother Nature's gift of serene and colorful landscapes. Where diversity makes us one, united towards a common goal. Where resiliency is achieved together. A strong infrastructure governance arising, where investments are waiting to flourish, and where creativity is inspired by tradition. Indonesia, where beautiful possibilities are offered.
Saya teringat masa saya masih di SMA, itu ada adik ibu saya, paman saya, yang bergejala batuk, kemudian makin kurus, sesak. Kami tidak tahu tentang TB saat itu, jadi akhirnya dianggap sebagai batuk biasa, tapi kemudian ada fase batuknya berdarah, sehingga dibawa ke puskesmas saat itu. Tetapi ternyata tidak tertolong, pada akhirnya paman saya itu meninggal.
Setelah di puskesmas baru saya menghubung-hubungkannya, dan saya berpikir jangan-jangan banyak orang di seluruh daerah, di kota-kota, di desa-desa, di banyak negara ini sebetulnya banyak pasien TB tapi masyarakat tidak tahu. Rumah Sakit Persahabatan di Jakarta ini adalah merupakan rumah sakit pusat rujukan untuk penyakit respirasi yang nasional ya. Jadi ada tiga kegiatan yang memang merupakan tugas kami ya. Pertama adalah pelayanan, kemudian pendidikan dan riset. Dan ya tentu saja saya senang sekali bertemu dengan pasien-pasien tuberkulosis, berinteraksi dengan mereka, memberikan harapan.
Menurut saya, masalah terbesar dalam mengurangi TB adalah kurangnya kemauan orang untuk memeriksakan diri. Awal mulanya saya tahu saya positif HIV. Saya menikah dengan suami saya ini. Dan di tahun 2020 saya punya TBRO.
Orang-orang dengan HIV ini sistem imunnya turun, rendah. Sehingga mudah sekali terinfeksi oleh kuman maupun bakteri atau virus apapun yang lain.
Awalnya saya tahu saya punya TB itu, awalnya saya batuk. Selama 2 bulan saya tidak sembuh, dan lalu saya mengajak suami saya untuk berobat ke puskesmas. Saya merasakan efek obat yang sangat berat, sampai muntah-muntah, sampai saya tuh kekurangan darah. Rasanya tuh saya udah kayaknya tuh saya udah nggak ada pikiran untuk hidup lagi gitu buat saya yang merasakan masalahnya, seperti takut menularkan ke orang lain, takut merasa dihindari, merasa dikucilkan, merasa dijauhin, ya pokoknya segala sesuatunya kayak minder gitu. Saya jarang berkumpul dengan sanak saudara, keluarga, teman, saya jarang keluar.
Dan sekarang bukan saja rumah sakit kami yang sudah melaksanakan pelayanan TB resisten obat ini, tapi lebih dari 250 center sekarang. Jadi ini suatu perkembangan yang luar biasa.
With all the support from the donors country or the global fund, we are especially able to establish the TB multi-drug resistant treatment center.
Global fund itu membantu kita untuk infrastruktur, terutama untuk diagnosis. Karena kita punya gene expert, kemudian kita juga punya MJIT.
We are using this expert machine to test not only for tuberculosis, but including for the COVID-19, especially in the remote area where the PCR tests are not available.
Jadi kalau seluruh lapisan masyarakat, seluruh lapisan pemangku kebijakan di atas sana juga melakukan ikhtiar untuk tuberkulosis sebagaimana untuk COVID, saya sangat-sangat yakin bahwa TB juga bisa dieliminasi.
Bang.
Wah, udah pada
Tante.
Iya dong.
Iya dong.
Ayo.
Kak, gimana kalau kita minum dulu?
Ayo, boleh.
Sebelum nyanyi. Cheers dulu dong.
Cheers.
Cheers. Apa kabarnya, Bang?
Ya, begitulah, Mayan.
Yaudah, kita nyanyi bareng ya?
Ayo. Bentar. Gimana kalau kita main truth order aja?
Ayo, gas.
Lebih seru kan? Aku putar botolnya ya. Ya.
Om kena.
Ayo kena. Ibu kena. Ibu kan gak ikutan.
Ayo lagi.
Ya, kakak kena tuh. Ya, Kakak kenapa? Kakak kenapa sih? Kok dari tadi batuk-batuk terus?
Nggak tahu nih udah 2 minggu kayak gini terus.
Wah, harus segera cek ke dokter, Bang.
Iya tuh bener.
Iya nih.
Setiap orang berpeluang yang sama mengalami TBC. Yang perlu disadari, risiko kita untuk terpapar cukup besar. Semakin segera cek, semakin cepat sembuh. Ingat 14-1 cek TBC. Jika 14 hari batuk tak reda, satu solusi, cek dokter segera. Ayo, temukan TBC, obati sampai sembuh. 14 hari batuk tak reda, satu solusi, cek dokter segera. Segera cek website di 141.stoptbindonesia.org kami.
We are dealing with diseases that knows no borders. We are dealing with diseases that knows no borders.
আমার নাম মোহাম্মদ আসাদ মিয়া। আমার জীবনে সবচেয়ে গুরুত্বপূর্ণ আমার পরিবার। আমি একজন স্বামী, আমি একজন ছেলে, আমি একজন বাবুর্চি। আমি যক্ষ্মা থেকে সুস্থতা লাভ করছি। বেশ কয়েক মাস আগে আমার মা খুব অসুস্থ হয়ে পড়ছিল। তখন আমার পাশের যে ক্লিনিক আছে, ক্লিনিকে নিয়ে গেলাম। ডাক্তার কিছু টেস্ট দিল। তখন এই টেস্টগুলো ছিল খুবই ব্যয়বহুল। তো ওই মুহূর্তে আমার কাছে কোনো টাকা পয়সা ছিল না। তো আমার শেষ একটা সম্বল ছিল চটপটির গাড়ি। সেই গাড়িটা আমি বিক্রি করে দিলাম। বিক্রি করে দিয়ে আমার মার ওই টেস্টগুলো আমি করালাম। তো ব্লাড টেস্ট করানোর পর বললো যে ব্লাড টেস্টে কোনো সমস্যা নেই, আপনার আম্মাকে সাময়িক এই ওষুধগুলো খাওয়ালে ঠিক হয়ে যাবে। তা 3-4 দিন খাওয়ালাম, খাওয়ানোর পরও কমলো না। দেওয়ার পরে তারপর সুস্থতা শুধু পিছনে যাইতে চাই। ওর মধ্যে আবার করোনা চলতেছে, তখন আমার সম্পূর্ণ ইনকাম সোর্সই বন্ধ হয়ে গেল। এই মুহূর্তে আমার তেমন একটা চিকিৎসা করতে পারি নাই। আমার শেষ সময় যে ব্যবসাটা ছিল সেটা আমার হাতছাড়া হয়ে গেল। আমি সব দিকে অন্ধকারে গেলাম। এর মধ্যে নিজের শরীর অবস্থাও তেমন একটা ভালো না। নিজে খুব অসুস্থ বোধ করতেছি, বুকে ব্যথা, সর্দি, কাশি। আমার অবস্থা ওই সময় যে অবস্থা ছিল, মানে খুবই কষ্ট। যেটা আমি বলতেছি এটা আমি বাস্তবে অনেক ইচ্ছে বেশি কষ্ট করছেন বাস্তবে ওই মুহূর্তে। তখন আমার এই অবস্থা দেখে আমার পাশের একজন আমাকে এসে বললো যে আপনি ব্র্যাকের একটা আপা আছে। তখন উনি আমাকে ওনার সাথে যোগাযোগ করিয়ে দিল। টিবি ক্লিনিকে নাম ওনার শাহনাজ আপা। কপ পরীক্ষা করালো আর এক্সরে করালো। করানোর পরে সেখানে আমার বললো যে আপনার তো যক্ষ্মা হয়েছে। তবে আমার আম্মার যে সমস্যাগুলো ছিল সেই সমস্যাগুলো শাহনাজ আপা দেখে বললো আপনি যে কোনো একটা ডাক্তারে দেখান। তখন ডাক্তারে দেখালাম। দেখানোর পর ওই ডাক্তার বললো যে আপনার আম্মার যক্ষ্মা হয়েছে এবং ফ্রিলি ওষুধগুলো খাই। প্রতিদিন 3টা করে ওষুধ আমাদের খাওয়াতো 6 মাস 6 মাস একটানা খাওয়ার পর তখন আমরা সুস্থ হয়েছি। যেহেতু এখন আমি এবং আমার মা আমরা দুজনেই সুস্থ, এখন আমার মনে অনেক সাহস আছে, শক্তি আছে। আমার একটা দোকান আছে, চটপটি দোকান। আমি মনের দিক দিয়ে এখন অনেক খুশি, আমি এখন সুস্থ, এর বেশি কিছু আর না। যে কোনো মূল্যে আমি লড়াই করতে এখন প্রস্তুত, আমার পরিবারের জন্য, আমার মায়ের জন্য, আমার নিজের সুস্থতার জন্য।
The doctor said that there's no need to worry because tuberculosis is treatable and curable. I just need to take my medicines and eat well. But tuberculosis makes me feel lost and alone. I miss my friends so much.
Seryoso ba yan?
Oh no. Uy. Nico. Oh, Nico.
Am I strong enough to overcome this? But I was never alone in my journey. I was so afraid I would lose my friends, my love. But I was wrong. They invested their love, care, and support for me. I was so happy to hear that I was free of tuberculosis. The doctor and the health workers helped me live. The medicines and treatment saved me. But most importantly, the hope and love my family and friends gave me helped me beat tuberculosis. My experience has inspired me. I want to invest in ending TB by supporting others in their journey of healing.
Behold, the beauty that is Indonesia, Mother Nature's gift of serene and colorful landscapes, where diversity makes us one, united towards a common goal, where resiliency is achieved together. A strong infrastructure governance arising, where investments are waiting to flourish, and where creativity is inspired by tradition. Indonesia, where beautiful possibilities are offered.
Saya teringat masa saya masih di SMA, itu ada adik ibu saya, paman saya, yang bergejala batuk, kemudian makin kurus, sesak. Kami tidak tahu tentang TB saat itu, jadi akhirnya dianggap sebagai batuk biasa, tapi kemudian ada fase batuknya berdarah, sehingga dibawa ke puskesmas saat itu, tetapi ternyata tidak tertolong. Pada akhirnya paman saya itu meninggal. Setelah di puskesmas baru saya menghubung-hubungkannya, dan saya berpikir jangan-jangan banyak orang di seluruh daerah, di kota-kota, di desa-desa, di banyak negara ini sebetulnya banyak pasien TB tapi masyarakat tidak tahu. Rumah sakit persahabatan di Jakarta ini adalah merupakan rumah sakit pusat rujukan untuk penyakit respirasi yang nasional ya. Jadi ada tiga kegiatan yang memang merupakan tugas kami ya. Pertama adalah pelayanan, kemudian pendidikan dan research. Dan ya tentu saja saya senang sekali bertemu dengan pasien-pasien tuberkulosis, berinteraksi dengan mereka, memberikan harapan.
Menurut saya, masalah terbesar dalam mengurangi TB adalah kurangnya kemauan orang untuk memeriksakan diri. Awal mulanya saya tahu saya positif HIV. Saya menikah dengan suami saya ini. Dan di tahun 2020 saya punya TBRO.
Orang-orang dengan HIV ini sistem imunnya turun, rendah. Sehingga mudah sekali terinfeksi oleh kuman maupun bakteri atau virus apapun yang lain.
Awalnya saya tahu saya punya TB itu, awalnya saya batuk. Selama 2 bulan saya tidak sembuh, dan lalu saya mengajak suami saya untuk berobat ke puskesmas. Saya merasakan efek obat yang sangat berat, sampai muntah-muntah, sampai saya tuh kekurangan darah. Rasanya tuh saya udah kayaknya tuh saya udah nggak ada pikiran untuk hidup lagi gitu buat saya yang merasakan masalahnya, seperti takut menularkan ke orang lain, takut merasa dihindari, merasa dikucilkan, merasa dijauhin, ya pokoknya segala sesuatunya saya minder gitu. Saya jarang berkumpul dengan sanak saudara, keluarga, teman, saya jarang keluar.
Dan sekarang bukan saja rumah sakit kami yang sudah melaksanakan pelayanan TB resisten obat ini, tapi lebih dari 250 center sekarang. Jadi ini suatu perkembangan yang luar biasa.
With all the support from the donors country or the global fund, we are especially able to establish the TB multi-drug resistant treatment center.
Global fund itu membantu kita untuk infrastruktur, terutama untuk diagnosis. Karena kita punya gene expert, kemudian kita juga punya MGIT.
We are using this expert machine to test not only for tuberculosis, but including for the COVID-19, especially in the remote area where the PCR tests are not available.
Jadi kalau seluruh lapisan masyarakat, seluruh lapisan pemangku kebijakan di atas sana juga melakukan ikhtiar untuk tuberkulosis sebagaimana untuk COVID, saya sangat-sangat yakin bahwa TB juga bisa dieliminasi.
Bang.
Wow, udah pada kumpul.
Tante.
Iya dong.
Iya dong.
Ayo, Om.
Kak, gimana kalau kita minum dulu?
Ayo, boleh.
Sambil nyanyi. Cheers dulu dong.
Cheers.
Cheers. Apa kabarnya, Bang?
Ya, begitulah Mayan.
Yaudah, kita nyanyi bareng ya.
Ayo. Bentar. Gimana kalau kita main truth order aja?
Ayo, gas.
Lebih seru kan? Aku puter botolnya ya. Ya.
Om kena.
Ayo kena. Ibu kena.
Ibu kan gak ikutan.
Ayo lagi.
Ya, kakak kena tuh. Ya, kakak kena tuh. Kakak kenapa sih? Kok dari tadi batuk-batuk terus?
Nggak tahu nih udah 2 minggu kayak gini terus.
Wah, harus segera cek ke dokter, Bang.
Iya tuh bener.
Iya nih.
Setiap orang berpeluang yang sama mengalami TBC. Yang perlu disadari, risiko kita untuk terpapar cukup besar. Semakin segera cek, semakin cepat sembuh. Ingat 14 cek TBC. Jika 14 hari batuk tak reda, satu solusi, cek dokter segera. Ayo, temukan TBC, obati sampai sembuh. 14 hari batuk tak reda, satu solusi, cek dokter segera. Segera cek website di 141.stoptbindonesia.org kami.
We are dealing with diseases that knows no borders. We are dealing with diseases that knows no borders.
আমার নাম মোহাম্মদ আসাদ মিয়া। আমার জীবনে সবচেয়ে গুরুত্বপূর্ণ আমার পরিবার। আমি একজন স্বামী, আমি একজন ছেলে, আমি একজন বাবুর্চি। আমি যক্ষ্মা থেকে সুস্থতা লাভ করছি। বেশ কয়েক মাস আগে আমার মা খুব অসুস্থ হয়ে পড়ছিল। তখন আমার পাশের যে ক্লিনিক আছে, ক্লিনিকে নিয়ে গেলাম। ডাক্তার কিছু টেস্ট দিল। তখন এই টেস্টগুলো ছিল খুবই ব্যয়বহুল। তো ওই মুহূর্তে আমার কাছে কোনো টাকা পয়সা ছিল না। তো আমার শেষ একটা সম্বল ছিল চটপটির গাড়ি। সেই গাড়িটা আমি বিক্রি করে দিলাম। বিক্রি করে দিয়ে আমার মার ওই টেস্টগুলো আমি করালাম। তো ব্লাড টেস্ট করানোর পর বললো যে ব্লাড টেস্টে কোনো সমস্যা নেই, আপনার আম্মাকে সাময়িক এই ওষুধগুলো খাওয়ালে ঠিক হয়ে যাবে। তা 3-4 দিন খাওয়ালাম, খাওয়ানোর পরও কমলো না। দেওয়ার পরে তারপর সুস্থতা শুধু পিছনে যাইতে চায়। ওর মধ্যে আবার করোনা চলতেছে, তখন আমার সম্পূর্ণ ইনকাম সোর্সই বন্ধ হয়ে গেল। এই মুহূর্তে আমার তেমন একটা চিকিৎসা করতে পারি নাই। আমার শেষ সময় যে ব্যবসাটা ছিল সেটা আমার হাতছাড়া হয়ে গেল। আমি সব দিকে অন্ধকারে গেলাম। এর মধ্যে নিজের শরীর অবস্থা তেমন একটা ভালো না। নিজে খুব অসুস্থ বোধ করতেছি, বুকে ব্যথা, সর্দি, কাশি। আমার অবস্থা ওই সময় যে অবস্থা ছিল, মানে খুবই কষ্ট। যেটা আমি বলতেছি এটা আমি বাস্তবে অনেক চেয়ে বেশি কষ্ট করছেন বাস্তবে ওই মুহূর্তে। তখন আমার এই অবস্থা অবস্থা দেখে আমার পাশের একজন আমাকে এসে বললো যে আপনি ব্ল্যাকের একটা আপা আছে, তখন উনি আমাকে ওনার সাথে যোগাযোগ করিয়ে দিল। টিবি ক্লিনিকে নাম ওনার শাহনাজ আপা, কফ পরীক্ষা করালো, এক্স-রে করালো। করানোর পরে সেখানে আমাকে বললো যে আপনার তো যক্ষ্মা হয়েছে। তবে আমার আম্মার যে সমস্যাগুলো ছিল সেই সমস্যাগুলো শাহনাজ আপা দেখে বললো আপনি যে কোনো একটা ডাক্তারে দেখান। তখন ডাক্তারে দেখালাম, দেখানোর পর ওই ডাক্তার বললো যে আপনার আম্মার যক্ষ্মা হয়েছে এবং ফ্রিলি ওষুধগুলো খাই। প্রতিদিন 3টা করে ওষুধ আমাদের খাওয়াতো 6 মাস। 6 মাস একটানা খাওয়ার পর তখন আমরা সুস্থ হয়েছি। যেহেতু এখন আমি এবং আমার মা আমরা দুজনেই সুস্থ, এখন আমার মনে অনেক সাহস আছে, শক্তি আছে। আমার একটা দোকান আছে, চটপটি দোকান। আমি মনের দিক দিয়ে এখন অনেক খুশি, আমি এখন সুস্থ, এর বেশি কিছু না। যে কোনো মূল্যে আমি লড়াই করতে এখন প্রস্তুত, আমার পরিবারের জন্য, আমার মায়ের জন্য, আমার নিজের সুস্থতার জন্য।
The doctor said that there's no need to worry because tuberculosis is treatable and curable. I just need to take my medicines and eat well. But tuberculosis makes me feel lost and alone. I miss my friends so much.
Seryoso ba yan?
Oh no. Uy,
Nico.
Nico. Oh, Nico.
Am I strong enough to overcome this? But I was never alone in my journey. I was so afraid I would lose my friends, my love. But I was wrong. They invested their love, care, and support for me. I was so happy to hear that I was free of tuberculosis. The doctor and the health workers helped me live. The medicines and treatment saved me. But most importantly, the hope and love my family and friends gave me helped me beat tuberculosis. My experience has inspired me. I want to invest in ending TB by supporting others in their journey of healing.
Behold, the beauty that is Indonesia. Mother Nature's gift of serene and colorful landscapes. Where diversity makes us one, united towards a common goal. Where resiliency is achieved together. A strong infrastructure governance arising, where investments are waiting to flourish. and where creativity is inspired by tradition. Indonesia, where beautiful possibilities are offered.
Saya teringat masa saya masih di SMA, itu ada adik ibu saya, paman saya, yang bergejala batuk, kemudian makin kurus, sesak. Kami tidak tahu tentang TB saat itu, jadi akhirnya dianggap sebagai batuk biasa, tapi kemudian ada fase batuknya berdarah, sehingga dibawa ke puskesmas saat itu, tetapi ternyata tidak tertolong. Pada akhirnya paman saya itu meninggal. Setelah di puskesmas baru saya menghubung-hubungkannya, dan saya berpikir jangan-jangan banyak orang di seluruh daerah, di kota-kota, di desa-desa, di banyak negara ini sebetulnya banyak pasien TB tapi masyarakat tidak tahu. Rumah sakit Persahabatan di Jakarta ini adalah merupakan rumah sakit pusat rujukan untuk penyakit respirasi yang nasional ya. Jadi ada tiga kegiatan yang memang merupakan tugas kami ya. Pertama adalah pelayanan, kemudian pendidikan dan research. Dan ya tentu saja saya senang sekali bertemu dengan pasien-pasien tuberkulosis, berinteraksi dengan mereka, memberikan harapan.
Menurut saya, masalah terbesar dalam mengurangi TB adalah kurangnya kemauan orang untuk memeriksakan diri. Awal mulanya saya tahu saya positif HIV. Saya menikah dengan suami saya ini. Dan di tahun 2020 saya punya TBRO.
Orang-orang dengan HIV ini sistem imunnya turun, rendah. Sehingga mudah sekali terinfeksi oleh kuman maupun bakteri atau virus apapun yang lain.
Awalnya saya tahu saya punya TB itu, awalnya saya batuk. Selama 2 bulan saya tidak sembuh, dan lalu saya mengajak suami saya untuk berobat ke puskesmas. Saya merasakan efek obat yang sangat berat, sampai muntah-muntah, sampai saya tuh kekurangan darah. Rasanya tuh saya udah kayaknya tuh saya udah nggak ada pikiran untuk hidup lagi gitu buat saya yang merasakan masalahnya, seperti takut menularkan ke orang lain, takut merasa dihindari, merasa dikucilkan, merasa dijauhin, ya pokoknya segala sesuatunya saya minder gitu. Saya jarang berkumpul dengan sanak saudara, keluarga, teman, saya jarang keluar.
Dan sekarang bukan saja rumah sakit kami yang sudah melaksanakan pelayanan TB resisten obat ini, tapi lebih dari 250 center sekarang. Jadi ini suatu perkembangan yang luar biasa.
With all the support from the donors country or the Global Fund, we are especially able to establish the TB multi-drug resistant treatment center.
Global Fund itu membantu kita untuk infrastruktur, terutama untuk diagnosis. Karena kita punya gene expert, kemudian kita juga punya MJIT.
We are using this expert machine to test not only for tuberculosis, but including for the COVID-19, especially in the remote area where the PCR tests are not available.
Jadi kalau seluruh lapisan masyarakat, seluruh lapisan pemangku kebijakan di atas sana juga melakukan ikhtiar untuk tuberkulosis sebagaimana untuk COVID, saya sangat-sangat yakin bahwa TB juga bisa dieliminasi.
Bang.
Wah, udah pada kumpul.
Tante.
Iya dong.
Iya dong.
Ayo.
Kak, gimana kalau kita minum dulu?
Ayo boleh.
Sebelum nyanyi. Cheers dulu dong.
Cheers.
Cheers. Apa kabarnya, Bang?
Ya, begitulah Mayan.
Yaudah, kita nyanyi bareng ya.
Ayo. Bentar. Gimana kalau kita main truth order aja?
Ayo, gas.
Lebih seru kan? Aku putar botolnya ya. Ya.
Om kena.
Ayo kena. Ibu kena.
Ibu kan gak ikutan.
Ayo lagi.
Ya, kakak kena tuh. Ya, kakak kena tuh. Kakak kenapa sih? Kok dari tadi batuk-batuk terus?
Nggak tahu nih udah 2 minggu kayak gini terus.
Wah, harus segera cek ke dokter, Bang.
Iya tuh bener.
Iya nih.
Setiap orang berpeluang yang sama mengalami TBC. Yang perlu disadari, risiko kita untuk terpapar cukup besar. Semakin segera cek, semakin cepat sembuh. Ingat 14-1 cek TBC. Jika 14 hari batuk tak reda, satu solusi, cek dokter segera. Ayo, temukan TBC, obati sampai sembuh. 14 hari batuk tak reda, satu solusi, cek dokter segera. Segera cek website di 141.stoptbindonesia.org kami.
We are dealing with diseases that knows no borders. We are dealing with diseases that knows no borders. We are dealing with diseases that knows no borders.
Anak adalah masa depan kita, masa depan bangsa. Mereka memiliki sejuta impian, cita-cita, dan harapan yang ingin mereka kejar. Namun, lebih dari 100.000 anak Indonesia terpaksa menunda mimpinya karena tertular TBC. Dukungan kita sangat berharga, selalu mengiringi langkahnya hingga dia menggapai mimpinya. TBC dapat dicegah dan diobati. Mari bersama bersama-sama lawan TBC. Untuk masa depan lebih cerah.
আমার নাম মোহাম্মদ আসাদ মিয়া। আমার জীবনে সবচেয়ে গুরুত্বপূর্ণ আমার পরিবার। আমি একজন স্বামী, আমি একজন ছেলে, আমি একজন বাবুর্চি। আমি যক্ষ্মা থেকে সুস্থতা লাভ করছি। বেশ কয়েক মাস আগে আমার মা খুব অসুস্থ হয়ে পড়ছিল। তখন আমার পাশের যে ক্লিনিক আছে, ক্লিনিকে নিয়ে গেলাম। ডাক্তার কিছু টেস্ট দিল। তখন এই টেস্টগুলো ছিল খুবই ব্যয়বহুল। তো ওই মুহূর্তে আমার কাছে কোনো টাকা পয়সা ছিল না। তো আমার শেষ একটা সম্বল ছিল চটপটির গাড়ি। সেই গাড়িটা আমি বিক্রি করে দিলাম। বিক্রি করে দিয়ে আমার মার ওই টেস্টগুলো আমি করালাম। তো ব্লাড টেস্ট করানোর পর বললো যে ব্লাড টেস্টে কোনো সমস্যা নেই, আপনার আম্মাকে সাময়িক এই ওষুধগুলো খাওয়ালে ঠিক হয়ে যাবে। তা 3-4 দিন খাওয়ালাম, খাওয়ানোর পরও কমলো না। দেওয়ার পরে তারপর সুস্থতা শুধু পিছনে যাইতে চাই। ওর মধ্যে আবার করোনা চলতেছে, তখন আমার সম্পূর্ণ ইনকাম সোর্স বন্ধ হয়ে গেল। এই মুহূর্তে আমার তেমন একটা চিকিৎসা করতে পারিনি। আমার শেষ সময় যে ব্যবসাটা ছিল সেটা আমার হাতছাড়া গেলাম, সব দিকে অন্ধকারে গেলাম। এর মধ্যে নিজের শরীর অবস্থা তেমন একটা ভালো না, নিজে খুব অসুস্থ বোধ করতেছি। বুকে ব্যথা, সর্দি, কাশি। আমার অবস্থা ওই সময় যে অবস্থা ছিল, মানে খুবই কষ্ট, যেটা আমি বলতেছি এটা আমি বাস্তবে অনেক ইচ্ছে বেশি কষ্ট করছেন বাস্তবে ওই মুহূর্তে। তখন আমার এই অবস্থা দেখে আমার পাশের একজন আমাকে এসে বললো যে আপনি ব্র্যাকের একটা আপা আছে। তখন উনি আমাকে ওনার সাথে যোগাযোগ করিয়ে দিল। টিবি ক্লিনিকে নাম ওনার শাহনাজ আপা, কফ পরীক্ষা করালো আর এক্সরে করালো। করানোর পরে সেখানে আমাকে বললো যে আপনার তো যক্ষ্মা হয়েছে। তবে আমার আম্মার যে সমস্যাগুলো ছিল সেই সমস্যাগুলো শাহনাজ আপা দেখে বললো আপনি যে কোনো একটা ডাক্তারে দেখান। তখন ডাক্তারে দেখালাম, দেখানোর পর ওই ডাক্তার বললো যে আপনার আম্মার যক্ষ্মা হয়েছে এবং ফ্রিলি ওষুধগুলো খাই। প্রতিদিন 3টা করে ওষুধ আমাদের খাওয়াতো 6 মাস। 6 মাস একটানা খাওয়ার পর তখন আমরা সুস্থ হয়েছি।
Ladies and gentlemen, the first Health Working Group site event on tuberculosis, prioritizing financing for tuberculosis response, overcoming COVID-19 disruption and building future pandemic preparedness, Day 2 will begin in a few moments. Inviting ladies and gentlemen and participants outside this room to join us in this room and to have a seat. Thank you.
আমার পরিবারের জন্য, আমার মায়ের জন্য, আমার নিজের সুস্থতার জন্য।
The doctor said that there's no need to worry because tuberculosis is treatable and curable. I just need to take my medicines and eat well. But tuberculosis makes me feel lost and alone. I miss my friends so much.
Seryoso ba yan?
Oh no. Uy.
Nico.
Oh, Nico.
Am I strong enough to overcome this? But I was never alone in my journey. I was so afraid I would lose my friends, my love. But I was wrong. They invested their love, care, and support for me. I was so happy to hear that I was free of tuberculosis. The doctor and the health workers helped me live. The medicines and treatment saved me. But most importantly, the hope and love my family and friends gave me helped me beat tuberculosis. My experience has inspired me. I want to invest in ending TB by supporting others in their journey of healing.
Behold, the beauty that is Indonesia. Mother Nature's gift of serene and colorful landscapes. Where diversity makes us one, united towards a common goal. Where resiliency is achieved together. A strong infrastructure governance arising, where investments are waiting to flourish, and where creativity is inspired by tradition. Indonesia, where beautiful possibilities are offered.
Saya teringat masa saya masih di SMA, itu ada adik ibu saya, paman saya, yang bergejala batuk, kemudian makin kurus, sesak. Kami tidak tahu tentang TB saat itu, jadi akhirnya dianggap sebagai batuk biasa, tapi kemudian ada fase batuknya berdarah, sehingga dibawa ke puskesmas saat itu, tetapi ternyata tidak tertolong. Pada akhirnya paman saya itu meninggal. Setelah di puskesmas baru saya menghubung-hubungkannya, dan saya berpikir jangan-jangan banyak orang di seluruh daerah, di kota-kota, di desa-desa, di banyak negara ini sebetulnya banyak pasien TB tapi masyarakat tidak tahu. Rumah sakit persahabatan di Jakarta ini adalah merupakan rumah sakit pusat rujukan untuk penyakit respirasi yang nasional ya. Jadi ada tiga kegiatan yang memang merupakan tugas kami ya. Pertama adalah pelayanan, kemudian pendidikan dan riset. Dan ya tentu saja saya senang sekali bertemu dengan pasien-pasien tuberkulosis, berinteraksi dengan mereka, memberikan harapan.
Menurut saya, masalah terbesar dalam mengurangi TB adalah kurangnya kemauan orang untuk memeriksakan diri. Awal mulanya saya tahu saya positif HIV. Saya menikah dengan suami saya ini. Dan di tahun 2020 saya punya TBRO.
Orang-orang dengan HIV ini sistem imunnya turun, rendah. Sehingga mudah sekali terinfeksi oleh kuman maupun bakteri atau virus apapun yang lain.
Awalnya saya tahu saya punya TB itu, awalnya saya batuk. Selama 2 bulan saya tidak sembuh. Dan lalu saya mengajak suami saya untuk berobat ke puskesmas. Saya merasakan efek obat yang sangat berat. Sampai muntah-muntah, sampai saya tuh kekurangan darah. Rasanya tuh saya udah kayaknya tuh saya udah nggak ada pikiran untuk hidup lagi gitu buat saya yang merasakan masalahnya, seperti takut menularkan ke orang lain, takut merasa dihindari, merasa dikucilkan, merasa dijauhin, ya pokoknya segala sesuatunya saya minder gitu. Saya jarang berkumpul dengan sanak saudara, keluarga, teman, saya jarang keluar.
Dan sekarang bukan saja rumah sakit kami yang sudah melaksanakan pelayanan TB resisten obat ini, tapi lebih dari 250 center sekarang. Jadi ini suatu perkembangan yang luar biasa.
With all the support from the donors country or the global fund, we are especially able to establish the TB multi-drug resistant treatment center.
Global fund itu membantu kita untuk infrastruktur, terutama untuk diagnosis. Karena kita punya gene expert, kemudian kita juga punya MJIT.
We are using this expert machine to test not only for tuberculosis, but including for the COVID-19, especially in the remote area where the PCR tests are not available.
Jadi kalau seluruh lapisan masyarakat, seluruh lapisan pemangku kebijakan di atas sana juga melakukan ikhtiar untuk tuberkulosis sebagaimana untuk COVID, saya sangat-sangat yakin bahwa TB juga bisa dieliminasi.
Ladies and gentlemen, the first Health Working Group site event on tuberculosis, prioritizing financing for tuberculosis response, overcoming COVID-19 disruption, and building future pandemic preparedness. Day 2 will begin in a few moments. Inviting ladies and gentlemen to have a seat. Thank you very much. Welcome back, ladies and gentlemen, to the second day of the series of prioritizing financing for tuberculosis response, overcoming COVID-19 disruption, and building future pandemic preparedness, day 2. Now we are going to start the 4th session with a discussion about financing to end tuberculosis in 2030, how the G20-led success will look. To brighten up this conference, may I have your applause, please, ladies and gentlemen, to our speakers and chair. Our speakers for this session are Balram, Bhargava, Head of the Indian Council of Medical Research, Peter M. Small, Medical Data and Technology Expert and Chief Medical Officer, HYFE, Chandra Yoga Aditama, Director of Postgraduate Studies, YRC University, and Guy Marks as the President of the Union. Ladies and gentlemen, the session will be conducted by the professor at University of Gajah Mada and the Board of National Research and Innovation Energy, Ibu Adi Utarini. Before we begin, distinguished speakers, I would like to remind you that when the time is up, you will slightly hear a gamelan sound just to wrap up your presentation. Thank you for your very kind attention. Ibu Adi Utarini, the floor is yours now.
Ladies and gentlemen, excellencies, speakers, and G20 member delegations. By now, we all have repeatedly heard, loud and clear, of the key facts about the unexpected global TB situation and responses. Nearly 10 million people fell ill with TB worldwide, with 2/3 of them reside in 8 countries. Increased TB death, 1.5 million people died from TB, making TB as the second leading infectious killer after COVID-19 and the leading cause of death for people with HIV. This higher unexpected outcome was contributed by multiple gaps. Gaps in the estimated number of people who fell ill with TB and the number of people diagnosed, global reduction in TB notifications, 15% lower number of people treated for drug-resistant TB with its low treatment success rate, co-epidemics of TB HIV, and only 1/3 of the targets for TB preventive treatment were achieved. Limited uptake of diagnostics, new drugs and regimens, and further slow progress in the space for research and development for new TB diagnostics, drugs and vaccines, I think provided the additional challenges for TB. Despite universal health coverage, access to quality TB services was disrupted, with the poor, marginalized, and vulnerable populations being mostly affected. Reversing these situations certainly require a huge increase, 4-fold of funding resources, as mentioned already yesterday. Sadly, current investment is still far from sufficient. Therefore, having adequate financing to end TB in 2030 is an acute need, and it could indeed be at stake, in danger, if the G20 member states cannot urgently mobilize resources from multiple sources. International donor funding, domestic funding, may it be public, private, philanthropies, and other sources. As we face serious reduction in the level of TB resources, coupled with lower health system capacity in spending the existing resources, business as usual is no longer usual. It's no longer acceptable. And this is, I think, one of the biggest lessons learned that we gained from the COVID-19 pandemic. We need to find innovative approaches to galvanize and translate political action into commitment and financing, innovative strategies and means to identify political leadership benchmarks to make faster and smarter progress that will put TB, global and national achievements back on track. I'm Adi Utarini, and I'm very honored to chair this 4th session. This session will focus on how the G20-led success will look. And we are very privileged to have 4 speakers in this session who will highlight the innovations in the field of TB vaccine, digital solutions, and further accelerated efforts to speed the innovation and to plan for success. Our first speaker is Professor Balram Bhargava, currently Director General of Indian Council of Medical Research. Prof. Bhargava is a professor in cardiology at the All Institute of Medical Sciences, New Delhi, and serves as the Executive Director for Stanford India Biodesign Center at the School of International Biodesign. So let us welcome Professor Balram Bhargava, and please kindly use the 7 minutes for the presentation, and at the end, provide takeaways for G20 to be addressed in the subsequent high-level G20 meetings. Please, Professor Bhargava.
Thank you, Honorable Chairperson, co-speakers, ladies and gentlemen. I would talk about the fact that research remains the key to India's response. More to be done at the country level, G20 level, and the global level. And I think this forum is going to be very, very important for suggesting to the G20 to increase funding. Next, please. Without research, India and the world are unlikely to meet NTB. So research remains the main gold standard. And so we have to set a good baseline. We have the prevalence survey. I'll talk a little bit about it. Implementation research, newer diagnostics, better therapeutics, latent TB, and vaccine efforts are an urgent priority for the globe. Next. The TB prevalence survey, which we just concluded last year, was done 60 years after the first survey in 1955 and 58. It was the largest survey in the world with 443 clusters done during the lockdown, and TB incidence is 2.6 million per year, and the TB prevalence found was 316 per 100,000 adult population. The survey was done in 1955 and 58 when we had the national survey done by the Indian Council of Medical Research, and we can see some of the pictures that the survey was done then in 1955, 56, 57, 58. And now, next. And now the survey has been done across the country, across 400 odd clusters, north to south, east to west, 4,000 kilometers north to south, 4,000 kilometers east to west, with these specialized buses with digitalized X-ray and CBNAT machines. Next. This was fully technology-driven survey today with the mobile phones, CBNAT, digital X-rays. Next. And we found the prevalence to be 316 per 100,000, and 18 of our states were much better than the national average, ranging from 115 to 301. Next. So implementation research has to be done to address these challenges for hard-to-reach areas, underserved population, caring for the elderly, children, women, innovative linking of diagnosis with treatment. Next. And we have seen that we have newer technologies like the handheld digital X-ray, which has a kappa agreement of 87%. This has been tested by us. Next. And newer, smart molecular diagnostics, which have been potential game changers, which is the TrueNat machine, which is a WHO pre-qualified, and we have more than 2,500 of these True Labs across the whole country, and they were repurposed for the COVID-19, but are back to for tuberculosis diagnosis. And we have the new skin test for latent tuberculosis, which has a very high sensitivity of 80% and specificity of 72%. Next. In terms of the drug protocols, we have to be innovative, and next, we have pragmatic and shorter TB treatments with high-dose rifampicin, with 4-dose treatment for only 6 months for XDR TB, and we are participating in multi-country trials for NTB and NTBQ, and we have developed standard treatment workflows, single-page workflows, which is also as an next. And we have recently done drone-based delivery for drugs for tuberculosis in the Northeast and different parts of the country where are hard-to-reach areas, and the drugs can be delivered very rapidly in a matter of minutes. Next. So we have these evidence-based national protocols for pediatric and extrapulmonary tuberculosis, and we have it on an app for widespread use for the country, and this has helped the nation tremendously. Next. We have the TB vaccine, the largest trial of TB vaccine, which has just completed our enrollment, and we have done the one-year follow-up in December 2021 at 12,000 participants with recombinant BCG and MIP versus placebo, and we should have the results of this study by the end of this year, and that would be a huge game changer for TB treatment. Next. There is a tremendous political commitment. As we know, the Delhi NTB Summit of 2018 showed local results, and we were asked to act globally, and that is what we have done in terms of funding and allocation of funds from the country. Next. So if we have to meet the NTB goals, we have to do the two things. One is to optimize current and new tools and pursue universal health coverage with social protection. This will reduce it once we optimize it. And we have to introduce the new tools, which is the vaccine, innovative prophylaxis and treatments, and point-of-care tests. We talked about the point-of-care tests, which we are now using, the molecular tests in the country. We are also talked about the innovative prophylaxis and shorter and pragmatic treatments, and we are at the cusp of the vaccine study and the results from that. If they are promising, then we should scale it up both nationally as well as internationally. Next. So in terms of global financing shortfall on TB research, I think it's a wake-up call for everyone. The United Nations high-level meeting had a commitment of $2 billion per annum for TB research and diagnosis, but only half of it, 915 million, was available, and out of which 496 million were allocated by India, and the lowest figure for the top 15 funder was $10 million. So India contributed tremendously for TB research and TB treatments. Next. And despite COVID, it is possible to end TB by 2030. As I mentioned, that research and innovation remains the key. Implementation research, better tools, newer diagnostics, newer management protocols, pragmatic protocols, and without the vaccine by 2025, it is difficult to end TB goal, and we need to pool our researchers from the G20. We need to pool our resources, and could G20 consider a pool funding mechanism for TB research and diagnostics as a public good? And I urge here that a minimum benchmark of $10 million per country be considered for TB R&D, a minimum $10 million. Next. And funding needs planning and not vice versa. And if we are united, we can. And with G20 leading from the front, we can meet our target of 2030. And our country has promised a more ambitious target. But G20 countries can lead development of new tools, and we have shown example of some of the new tools that we have deployed in India in a large country, and I think learnings from this could be utilized. We could mobilize global opportunity and funding, align national efforts with network to eliminate TB in a mission mode project, and it has to be mission mode. I think it could be a G20 mission. Global and regional research platforms and mechanisms of funding.
Professor Bhargava, pardon me.
And this is my last slide. This is my last slide. And set up benchmark for funding and identify common gaps, engage researchers with common thematic area protocol in each country, and research capacity enhancement in high burden G20. So G20 can lead from the front, and that is how I urge today. Thank you.
Thank you, Professor Bhargava, and thank you for sharing with us the latest research, and we certainly look forward to the result of the latest done there. All right, we now have to move to our second speaker, and we will hear Dr. Peter Small, Chief Medical Officer of HYFE. He has a long history of bringing innovation to TB care and prevention, and being trained at the University of California, He built and ran the TB program at the Bill and Melinda Gates Foundation and piloted the use of drones to deliver TB care in remote communities. After stints at the Rockefeller Foundation and Global Health Lab, he recently joined HYFE, I hope I pronounce it correctly. This is a high-growth startup company that seeks to use acoustic epidemiology to transform the world's approach to cough. Very inspiring. So please welcome Dr. Peter Small, MD, and please also kindly use your 7-minute time for the speech.
I appreciate the opportunity to speak here at this year's G20 meeting. Together, the G20 nations share about 50% of the global burden of TB and an even greater percentage of the opportunity, and I would add, the responsibility to fight TB globally. The premise of my presentation is that the G20 is uniquely suited to shape and scale transformational, data-driven digital solutions in their countries, and to ensure that these solutions are made available to the rest of the world. Let me start with some context. It's easy to forget that 2019 was a golden year in which new tools and increased financial commitments showed that TB was solvable. A comprehensive assessment by a Lancet commission again showed that the diagnosis and treatment of TB was the most cost-effective intervention of all diseases studied. $1 invested in TB returns $24 of benefit. Achieving these returns on investments had become even more likely because the TB community was beginning to embrace the use of better data and pilot a variety of digital tools to improve the quality and the cost effectiveness of TB care. For example, the use of AI to read chest x-rays and identify TB was shown to greatly improve screening and triage. Evaluations by Stop TB partnerships and others had shown that AI can outperform radiologists, and based on this evidence, the WHO recommended automated radiography for TB screening and triage. The ability to digitally connect molecular diagnostic instruments with software like Aspect and data to care was shown to better link diagnosis to care and in the process speed up testing, decrease stockouts, and increase trust between laboratories and programs. Mobile apps were developed to help frontline workers and empower communities. For example, Damagi's ComCare allowed local developers to quickly build custom mobile software that improved the quality and efficiency of their frontline workers. One impact, developed by the Stop TB Partnership, Dure Technology, and the TB community, had an app that collects, analyzes, and acts in real time to identify and remove barriers to accessing TB care. Digital adherence technology was introduced to help patients take their medicines. Importantly, technology such as that of WisePill and providers of video observed therapy also helped to foster a global shift in the mindset of TB control programs towards a more patient-centric model of care. TB Reach showed digital adherence technology to be feasible, acceptable, and impactful. TB control programs began to use digital approaches to integrate and improve service delivery. For example, Everwell Health Solutions supported India's national TB program to develop, deploy, and scale a national data system by enabling real-time dashboards, integrating government payments with patients' banks, and making all of this part of both public and private healthcare provisions. NICSHE improved the timeliness of national data from months to minutes. But sadly, today, just a few years later, global TB care and control is in the midst of a crisis. COVID has had devastating effects on every aspect of global health, but TB services have been disproportionately impacted. In the past 2 years, the number of undiagnosed and untreated cases has skyrocketed, and for the first time in a decade, TB mortality has increased. But I believe that in the right perspective, crises are opportunities in disguise. The silver lining of COVID is that in their response to it, the G20 showed how quickly a health system can muster a response to a health threat if they embrace the power of digital data and health. Central to the COVID response was the use of digital tools like Health Connect from PRECALT that enabled the early detection, mapping, and management of patient care while increasing patient empowerment with tools for triage and diagnosis. Together, these digital systems enabled better resource allocation, patient care, contact tracing, and infection control. This simply could not have happened had they not embraced mobile phones, the power of digital data, and state-of-the-art digital technology. The major point of my presentation is that there is a clear path out of today's TB crisis. Integrate and scale what TB showed to be possible in 2019 using the digital mindset of the COVID response. COVID has shown us the impact of patient empowerment, that people can and will self-test. TB programs must double down on trends and technologies for patient empowerment, remote patient monitoring, and delivering care to patients' home. TB must be better integrated into mobile phone apps used by primary healthcare workers so that all providers consider TB when treating chronic cough, perform the right evaluations, and perhaps we can achieve the holy grail of integrating TB screening and case finding into primary healthcare. Public health dashboards that have been developed for COVID should be expanded to include event-generated TB data, such as that coming from AI-enabled chest X-ray machines and connected diagnostic instruments. And in the process, we can break down the silos that have plagued public health. With integrated digital health records, community health workers would no longer need to make separate visits for vaccination, prenatal care, and TB case management. By embracing digital technology, TB care and control would also hitch its wagon to the exponential engine of global innovation. I want to take a minute to talk about one of them, the untapped potential of ambient sound to help us understand, diagnose, treat, and monitor health conditions. The ubiquity of smartphones is spawning a new field, acoustic epidemiology, which is the use of sound to monitor and track diseases. I am personally super excited by this. After a career as an academic and philanthropic funder, I recently left the public sector to join HYFE, a small startup whose ambition is nothing short of changing the way the world manages cough. The current approach to cough is rather pathetic. It's critical in finding and treating TB patients, and yet we don't actually measure cough. Together with the Gates Foundation and Global Health Labs, HYFE has created an app that anyone with a smartphone anywhere in the world can download and use for free. This app essentially turns a phone into a Fitbit for cough that allows patients to passively and unobtrusively monitor their cough while preserving their privacy. I think this technology will help individuals know if their TB is resolving with treatment and promptly recognize if their treatment is failing. Several multinational research teams are working to develop a Shazam for cough that might even help diagnose TB based just on the sound of the cough. Is that possible? Well, I don't know, but if it is, imagine a world in which anyone with a phone can diagnose their own TB. HYFE is not alone in the vision that mobile phones will become the workhorse for global health, and our cough app is just one example of thousands of digital technologies that are being developed that have the potential to help solve the TB problem. The path is not without barriers that the G20 are uniquely suited to address. A recent study done by Stop TB and the Global Fund showed that countries have an ambition to go global and digital, but many will require significant technical and financial support. I'll end with a simple ask based on my premise that in order to bend the epidemic curve downward, we need to bend the innovation curve upward. I think this message is so simple that I had my daughter write it out. I asked this group to call on the G20 to bring the sense of urgency and the focus on data and digital technology that they demonstrated during the COVID response to other global health threats, starting with TB. Failing to do so will perpetuate the chaotic and inefficient propagation of unimpactful technology and ultimately cost billions of dollars and millions of avertible deaths. Whereas, with leadership and strategic funding from the G20, we can pivot tuberculosis from crisis to exponential progress. Thank you.
Thank you very much. So certainly still a large opportunity to develop and use digital technology to enable TB to be indicators to be achieved at a faster rate. So from digital technology, let us now move to the third speaker, who is from Indonesia. I'd like to invite Prof. Chandra Yoga Aditama, currently serves as a director of postgraduate school at YRC University. And Prof. Chandra Yoga is also a professor at the Faculty of Medicine, University of Indonesia, member of the governing board of SEAMEO, and adjunct professor in the Center for Environment and Population Health at Griffith University, Australia. He has a long and important experiences nationally and also regionally. He was acting director as the WHO Southeast Regional Office. And prior to that, he also served as the Director General of Disease Prevention and Control and Environment Health at the Ministry of Health, Indonesia. So to Prof. Chandra Yoga, please kindly use your 7 minutes for the presentation and to ensure also to give us some takeaway message for the G20 to bring it to the high-level G20 meetings. Please, Prof. Chandra.
Thank you, Prof. Utarini. If I may just share my slide and please count the 7 minutes after my slide was shown. So distinguished delegates, colleagues, ladies and gentlemen, our discussion today, session is regarding the financing to end TB in 2030. So I will discuss some part of the financial aspect of the funding gap of TB. We all know that this is just based on the global TB report. This line is the global target set for a UN high-level meeting of 13 billion, and these are the funding available globally from year to year. So we can see it's quite a gap between the target and the availability of the funding up to 2020. And this situation is still up until now as well. So this is a global situation, and for the Southeast Asia region of WHO, the TB financing, the national TB budget of all of 11 countries of the Southeast Asia region of WHO, the national TB budget for 2021 was 1.3 million US dollars, 40% from funding sources. Domestic funding, 26% from international, and still unfunded 34%. So you can see here 1.39 budget, 34 still not yet funded, but basically what the need for the Southeast Asia region, it was 3 billion. So even 1.3 is not enough. So if you are talking about funding gap, there are 3 aspects I would like to mention. One, there is a gap even in budget plan. The budget plan is not yet enough to show what is the real budget needed. So in this regard, we should have a better budget plan to fulfill the need. That is the first issue of the funding gap. The second issue of the funding gap, even if we have a good budget plan, but the fund availability was not always there. So as I mentioned, it is 1.39 billion budget plan for the 3 billion target. But out of this 1.39 billion, only 1 billion, the real budget is available. So besides making a better budget plan, but of course the national funding should also be increased. This is the report on the World TB Day by the WHO Southeast Asia region. They have already increased. I mean, countries already increased their budget triple from 2015 up to 2021, but still not enough. So there are already a new regional strategic plan. It shows the shortfalls. So with the COVID-19 pandemic, surely we have to overcome this situation better. So I said the first issue of funding gap is funding gap. I mean, problem in the budget plan. Secondly, in the money availability, and the third one, we have to prepare a budget for the future as well. The first speaker already mentioned about the new vaccine. So if the vaccine is there, there will be a budget needed for the new vaccine implementation. There will be also budget needed for introduction and rollout of new drug and regimen, which are for sure it will be better efficacy, but perhaps more costly. And there might be, not might be, but there are already a new diagnostic tool for quick and complete diagnosis like Gene Expert, genome sequencing, which also need a budget. So there are funding gaps, and the funding gaps has to be overcome. So as the Professor Utarini moderator asked us to give some message, if I may, I share 7 messages for us to discuss furthermore. Number 1, this is from the Utarini partnership. The first message, world leader must step up, triple or quadruple the funding to save life to end TB by 2030. Of course, including G20 world leader. That's number 1. Number 2 is, as I mentioned earlier, domestic funding must be increased, and it needs advocacy and political commitment. The third possible way to get funding is for some kind of taxation system for disease specific, already happening with unit aid through airline tax. The fifth one is to find so many possible innovative mechanisms. For instance, from international donor agency, we know there is a loan buyback global fund system that the country can use the money for strengthen their TB control program. The fifth one is how we engage the philanthropists and the private sector. The sixth one is not only finding more money, but also, to do a cost efficiency. This can be done through integration of program and services such as TB and tobacco control, TB and diabetes, or mutual usage of diagnostic tools such as Gen Expert platform can be used for multiple diseases, like now used for COVID as well as for TB. Integrated laboratory and treatment delivery infrastructure, strengthening community involvement, community engagement. So this will also play an important role to fill up the gap of funding gap. And the last one, the seventh part, is as we know, the TB is a disease of marginalized, and investing on it is a cost-effective program. One of the scientific data, as we all know, saying that every dollar invested in apartment TB, that's return on average of $43 in economic benefits, and additional 20 years of working productively for the people. So, and it is also mentioned, I think, by Professor Utarini in the beginning of our discussion. This will be very in line with our UHC strategy, Universal Health Coverage Strategy, reaching out to those at the end of the queue. For the last message, message number 7, if we want to ending TB, we have to invest now, or we have to sorry later, or at least we have to pay much more later. Since I'm the only Indonesian in this forum speaker, so I just want to share with you, this is how we wrote tuberculosis in Indonesian language, and up here, this is how we say thank you from Indonesian language. So terima kasih, thank you very much.
Thank you, Professor Chandra Yoga with the seven strategies, yeah, for the takeaway messages, very important messages. We will now invite our final speaker, and our final speaker is the President of the Union, Professor Guy Marks, who has global contribution to asthma, chronic lung disease, TB, and air pollution, and have transformed global responses to these health problems. Professor Marks is a respiratory physician and epidemiologist and a public health physician with strong commitment to capacity building for lung health research. He also leads the Respiratory and Environment Epidemiology Group at the Wolcott Institute of Medical Research since 1997. So I would like to invite Professor Marks for the presentation. You have 7 minutes for the presentation, and kindly end with the takeaway messages. Your voice is not yet heard, Professor Mark.
Can you hear me now?
Yes, yes, clear.
Can you see my slides? I'm not sure whether you can see my slides. I hope you can see my slides. Thank you very much for inviting me to speak. Thank you, Professor Adi Utarini, and thank you to distinguished guests for inviting me to speak. My name is Guy Marks. I'm the president of the Union, and the Union is, for those who are not aware of it, is now 102 years old public health organisation. And we have a vision for a world which is free of tuberculosis and lung disease. And we strive to end suffering due to tuberculosis and lung diseases by advancing better prevention and care. We seek to achieve this by the generation, dissemination and implementation of knowledge into policy and practice. We're a scientific organisation. We aim to ensure that no one is left behind and that people are treated equally. And we have a focus on vulnerable and marginalised populations and communities. We've heard already today that the incidence of TB is declining very slowly. And we are not, in fact, on track now to achieve the global targets for ending TB, which we've all signed up for. We need to achieve, we currently have a rate of decline of about 2% per year in the incidence of tuberculosis, and we need to achieve a rate of 10%. This seems like a very big increase, but in fact that rate of decline has been observed many times previously, and in many of the so-called developed countries in the 1950s, 60s and 70s, the rates of decline were even faster, during a time in which active case finding using mass miniature chest X-ray was being used to screen populations for TB. And I can share with you here one slide from my own country, Australia. This shows actually deaths, but similar data would be seen if we looked at incidence. And you can see here in the middle of the slide that during the time in which the National Tuberculosis Campaign was being implemented in Australia from the mid-1940s until the mid-1970s, a campaign that centred on community-wide screening of the population by radiology, there was an incredibly rapid decline in both deaths and incidents due to tuberculosis. The decline was so rapid that, and so persistent that by 1974 the campaign was abandoned because there were essentially no more cases to find. And this was replicated in many other countries in Europe, Western Europe, North America and into Japan, where the campaigns came to an end because cases were not being found. Today's meeting is about investment and finances, and it's about investment. We do need more investment in tuberculosis control to end TB. Well, we need to make sure that we invest in interventions that actually do reduce the incidence of TB. We need to make sure we have a return on investment. I'm going to talk to you about one such intervention, and it's one of several possible interventions, but I want, in the short time available, to focus on this one: community-wide, symptom-agnostic, active case finding or screening. And by symptom-agnostic, what I mean is screening the population regardless of the presence of symptoms. The rationale for this is that in countries with a very high burden of tuberculosis, everybody is at risk of TB. In contrast to low burden countries where most TB occurs in high risk groups, in high burden countries, most cases do not occur in high risk groups. They occur in the general community. Also, in contrast to low burden countries, most people develop TB soon after being infected by another person with TB. In low burden countries, like the United States, Europe and Australia, most cases of TB occur due to late reactivation of latent tuberculosis. But in high burden countries, that is not the case. Most cases occur due to recent infection and transmission. The other thing that we now are aware of is that many people who have TB do not have symptoms or do not have typical symptoms of TB. And without typical symptoms, and sometimes without any symptoms at all, people will not seek care and cannot be diagnosed by the routine healthcare system. However, they're still infectious to others and can still transmit the disease to others. The rationale and the hypothesis that we wanted to test was that finding and treating all infectious cases of TB in a community will interrupt the epidemic chain of transmission and have a profound effect on the prevalence and incidence of tuberculosis. We tested this in a randomized controlled trial in a province of Vietnam, the province of Cà Mau, which is the southernmost province of Vietnam and has a high burden of tuberculosis. We tested it in 120 clusters or subcommunes, 60 of which received an active screening intervention and 60 of which were control clusters in which we did not intervene. The total population involved in this study was about 120,000 people, quite a large population. The intervention involved community engagement, a household census where we went from house to house to enumerate the whole population, screening by collection, in this case of sputum. Could have been done by X-ray, but we did sputum collection from everybody who was capable of producing sputum, and we tested the sputum using a molecular test, Expert MTB. This intervention over 4 years had a profound effect on the prevalence of tuberculosis. Here you can see the prevalence of cases in each of the 4 years in which we did the screening. And you can see, that over the 4 years of the study, the reduction in prevalence was 72%. In the final year, we screened a control group, similar size in the same area, and we found that but who had not previously been screened, and we found that the prevalence was 44% lower. So this active case finding intervention resulted in something between a 44% and 72% reduction in the prevalence of TB. I remind you that previously I reported that the overall reduction in incidence has usually been about 2% per year in the incidence of tuberculosis. We also looked at incidence in this population by looking at people who were screened in 1 year and found not to have TB, and then screened the following year and found to have TB. And we found that over the period of the study, we were able to reduce the incidence of TB, new diagnosis in people who did not previously have TB, by 57%. This reduction of 38% in 1 year and 57% in the next year represent people who never developed TB, who were prevented from developing TB. They never need to be diagnosed or treated. This is the return on investment. These are people who, cases that were prevented due to prevention of recent transmission. In this case, in this study, we did not do anything to children. The intervention was implemented only in adults, where we did active case finding and screening for TB in people aged 15 and over. But after the study was ended, we measured the prevalence of TB infection in children using a quantiferon test. And we showed that in the control group, the prevalence of TB infection was 8%, but it was only half this in the active intervention villages. So finding and treating cases of TB in the population prevented infection in children and probably also in adults in these populations.
Professor Mark, please kindly wrap up the presentation.
Okay.
Thank you.
So I will. So we have evidence that high burden settings for TB, community-wide symptom agnostic active case finding is effective. It produces a rapid decline in incidence and interrupts community transmission. We need to scale this up with operational and implementation research and investment. And I think we could start with the G20 and possibly start with some of the high burden countries in the G20, including perhaps Indonesia. So I finish there and I thank you for your attention. Thank you very much.
Thank you, Professor Mark. So we have already heard from our 4 speakers in this session, sharing their research, their experiences, thoughts, and also future vision. And I believe this session provides rich inspirations to keep us recover together and recover stronger by finding innovative ways to obtain financing to end TB in 2030. And with this, I now return the session to the organizer. Thank you.
Thank you very much, Ibu Adi Utarini, for leading the session. Thank you once again, and to all speakers. Thank you very much for the knowledge, very insightful. So now, ladies and gentlemen, we're going to have break for 10 minutes for preparing the next session. And then we will going back to have the summary report of the site event on TB. So we're going to have break for 10 minutes from now. Thank you.
1 month.
Berarti Attention please, ladies and gentlemen. Attention please, ladies and gentlemen. We're going to continue our agenda today for having summary report of the side event on TB. Inviting all participants to have a seat because we will continue our agenda today to have the summary report of the side event on TB. Thank you. Okay, thank you very much, ladies and gentlemen, for coming back here again. Continuing the TB side event on financing for TB response, overcoming COVID-19 disruption, and building future pandemic preparedness. And now we are in our second day. The next one, ladies and gentlemen, we're going to have the fifth session. We will have the summary report of the side event on TB. We would like to invite Special Advisor to the Ministry of Health and Politics and Health Globalization, Kirana Pritasari, to start the session. The floor is yours.
Thank you. Honorable members of Health Working Group and participants, my name is Kirana Pritasari. In this session, I will read the report, the summary report of our today's side event, TB on financing for TB response, overcoming COVID-19 disruption, and building future pandemic preparedness. The G20 acknowledged that the G20 has played a crucial role in fostering global collaboration and to address global health challenges. And this first Health Working Group side event has been a valuable seminar to discuss the existing challenges in TB response. The summary report of first Health Working Group side event on tuberculosis is drafted by the Indonesian G20 presidency. The side event was held in hybrid form from 29 to 30 March, aiming to highlight the need to mobilize additional resources in financing for TB response through multilateral, bilateral, and domestic mechanisms. Purpose of a call to action document outlining milestones of efforts to increase G20 countries' investments for TB response. In the keynote speeches session, speakers noted a common aspiration to strengthen effort to end TB by 2030 amid significant disruption caused by or related to the COVID pandemic. Speakers emphasized that for the first time in 20 years, TB mortality is increasing. Speakers acknowledge that fundings and investment for TB response remain a challenge to overcome. Ensuring innovative funding and effective investment to scale up public health infrastructure and healthcare is essential to prevent, diagnose, and treat all people affected by the disease. In addition, speakers also stressed the importance of investing in TB research and development, particularly on expanding the development of rapid diagnostic tests, effective vaccines, and affordable treatment regimen for TB. Developing real-time surveillance for TB and supporting an agile and data-driven decision-making process also need to be enhanced. During the G20 Leadership to End TB session, speakers highlighted how strong political commitments and multilateral can accelerate development, deployment, and implementation of novel solutions in COVID-19 response. Strengthening collaboration is needed to overcome TB through a people-centered approach by abolishing stigma or any form of prejudice and addressing the needs of communities for quality services with human right-based and gender equality principles. The first panel session, current efforts and financing toward ending TB are not sufficient to meet 2030 target, discuss that action as well as investments were falling far short to reach agreed target in the political declaration on the fight against TB published the UN General Assembly high-level meeting in 2018. The cost of financial inaction will cause substantial impact in TB control, particularly drug-resistant TB, with enormous implication for global health security and antimicrobial resistance. The investment in TB to reach an TB target is estimated at $230 billion US. Annually, investment from TB countries on TB care and prevention, as well as TB research and development, need to increase fourfold in 2030 and 2030. In the second session, alternative and innovative approaches to expand financing to end TB elaborated that ending the epidemic requires more rational investment to match its burden and impact on life and the economy. The G20 countries were urged to forge effective partnership with all relevant stakeholders, including TB survivors, parliamentarians, civil society, technical and multilateral agencies, private sectors, development banks, and philanthropies to avert TB death and economic losses. In the third panel session, development of airborne infection defense approach noted the need to strengthen TB response that is coherent and complementary to future airborne pandemic prevention, preparedness, and response. Speakers stressed the need for G20 member countries to recognize TB as a global health security threat and increase investment on their current response to TB and COVID-19 and build on TB platforms to improve pandemic preparedness systems for future airborne pandemics. Speakers also mentioned the inequality in access to medicine and technology due to intellectual property issues and hesitancy in drug manufacturing in global South country. The fourth panel session, Financing to End TB in 2030, how the G20-led success will look, outline lack of research and development, derails advancements. The meeting highlighted that investing in TB is one of the most cost-effective investments to achieve the Sustainable Development Goals. Based on modeling in 2015, in average, with an estimation of investing $907 to reach and ensure an individual for latent and active TB diagnosed and treated will benefit in saving to $38,594 US$ and 20 life years. Failure to finance TB response to reverse the impact of the pandemic on TB response and to meet the end TB targets by 2030 will cause massive social, economic, and public health repercussions, particularly on controlling multi-drug resistant TB. There is a pressing need for the G20 to adequately and sustainably invest in research, capacity building, data and technology transfer, and real-time surveillance to accelerate the research and development pace of new countermeasures, including novel vaccines, diagnostics, and quality, safe, effective, and shorter treatment regimen for combating drug-resistant forms of TB. The Indonesia G20 presidency proposed the following timeline to consult with G20 member states, invited countries, international organizations, and representatives of the Health Working Group to further discuss the call to action on financing for TB response. First week of April 2022, the Indonesia G20 presidency will share the summary of this meeting with the attached annex of the draft call to action to all participants. End of second week of April, the Indonesian G20 presidency will hold an informal consultation meeting to discuss the draft of the call to action document. First week of May, period of draft revision circulation of consolidated call to action. And end of May or early June, the Indonesian G20 presidency will disseminate the final draft call to action to gain final input, and if there no objection, the call to action will be adopted as part of the declaration of the G20 health ministers in the high Minister meeting in October 2022. Thank you, all colleagues, for actively participating and sharing your thoughts throughout the session. On behalf of the Indonesian Presidency, I apologize for the short notice regarding the draft outcome document. I express my gratitude and take notes of your written comment. We will send this summary and the draft of call to action according to the timeline, and therefore I invite all member countries, invited countries, international organizations, and participants of First Health Working Group to give written comment through email. Based on strong commitment from previous presidencies from 2017-2021, we have arrived at this moment to hold the first ever G20 side event on TB. The Indonesia G20 presidency wants to highlight that investment in TB is critical to solve global health challenges and to support economic recovery in G20 countries and the world. We ask your continuous support and active support in advancing the TB financing agenda during engagement from the Indonesia G20 presidency and hopefully in subsequent presidency. Thank you.
Applause please, ladies and gentlemen. Thank you very much, Ibu Kirana Pritasari, for delivering the summary report of the site event on TB. Thank you, Ibu. The next one, ladies and gentlemen, we have come to end of all of our seminar, and to close this event, I am honored to invite the Vice Minister of Health of Indonesia, Bapak Dante Saksono Harbuono, to give his closing statement. Bapak Dante, the stage is yours.
Honorable delegates, ladies and gentlemen, yesterday our minister told a story of a young German physician, Robert Koch, who made a path-breaking finding of Mycobacterium tuberculosis. It was his persistent commitment and eagerness to save humanity that led him to the discovery. Last night, in our gala, you witnessed one of Indonesian history plays, the Candi Prambanan. In this its story of Candi was made by persistent man Bandung Bondowoso to gain her a beautiful princess. It was again the example of persistence and commitment. G20 leaders and representatives, in this occasion, allow me to not reiterate the statistic of tuberculosis. The reports are widely available on the website of WHO, Global Fund, USAID, World Bank, Stop TB Partnership, the Union, Caucus, and many other global or domestic organizations. Going forward, our people, a father, a mother, or a child who suffer every day from bloody cough, and their family who are at risk getting infected, need not only the persistence to writing scientific report, they also need our commitment in taking extra action of making $20 billion investment by 2030. What kind of extra action investment every country needs? First, increasing international domestic financing, especially for tuberculosis through active involvement of government, parliament, and private sector. Second, ensure that tuberculosis tracing, testing, treatment, and vaccine are covered through better coordination and integration of financing through budget and national health insurance. Third, mobilize a potential budget from high net worth individuals, philanthropic, and companies to finance our global research and technology development for handy diagnostic tool, vaccine, shoulder regimen drugs. Ladies and gentlemen, as the leader of this year's G20 presidency, Indonesia is committed to improve the investment for TB. Last night, the Minister of Health of Indonesia and all of us witnessed the government of Special Region of Yogyakarta sign their renewed commitment to accelerate their effort in achieve TB eliminated target. I promise you that more action are coming because we believe the more we invest in TB today, the more of people we can save tomorrow. We will target $20 billion investment. I urge you everyone to send a message, to make a call, to create the noise for everybody to invest. It seems impossible, but with our persistence, I am sure it is possible. Lastly, I appreciate everyone's commitment to each side event. Your input and through are invaluable for those who attending the session in person. I wish you stay Yogyakarta a pleasant and memorable one. See you at the second health working group in June. Thank you so much.
Thank you, Bapak Dante Saksono, for wrap up this conference with giving the closing statement. So now, ladies and gentlemen, here we are at the end of our event. But before we end this conference, I would like to remind you, please do not forget to provide your feedback form by scanning QR code as seen on the screen. Yes, this is the QR code. So please, once again, do not forget to provide your feedback form by scanning QR code as seen on the screen. Ladies and gentlemen, here we are now at the end of our event. Lastly, let us listen to messages from TB survivors to the G20. May their message move us forward with renewed commitment and decisive actions to invest more and invest better in ending tuberculosis. I'm Santi Zaidan. Thank you very much, and wassalamualaikum warahmatullahi wabarakatuh.
Tuberculosis.
Almost 1 million South Africans have died as a result of TB since 2010.
It's highly contagious, and it's one of the leading causes of death.
TB is the 13th leading cause of death.
The disease is usually transmitted person to person through the air.
The weapons used to fight tuberculosis are now completely outdated.
4,100 people die.
Tuberculosis is one disease that seems to be taken for granted by millions of people.
Pada saat pertama kali tahu menderita tuberkulosis, tentu itu sangat manusiawi. Semua orang itu sedih, kaget, bingung, dan putus asa tentunya ya, harus mencari pertolongan dan informasi kemana. Tentu ini secara ekonomi saya akan berpengaruh banget karena saya tidak bisa bekerja lagi.
I get the stigma and discrimination when I giving birth. That time it should be one of the happiest time for me, but because I was placed in the glass isolation room, and that moment my privacy and confidentiality were ignored. That moment I have never more embarrassed, and despite of being a mother of even newborn, and that time I feel that more alone.
In my case, I was told by doctor not to tell anyone that I have tuberculosis. Otherwise, I would be
branded for life. Uncertainty terrifies people, that you don't know what's next and how long, and there was never an answer, of course. And I was rushed to a hospital and I was isolated for 7 months. And I told this to my mother, like, Mom, you have to get prepared that after I'm discharged, I will talk about tuberculosis very loudly.
If you think it's hard to diagnose lung TB, that is pulmonary TB, imagine how much harder it is to diagnose extrapulmonary TB, that is TB in any other part of your body, like it was for me, in my bone and my lymph nodes. I couldn't believe what I was hearing, that this was the state of TB in the 21st century.
Ini juga menjadi perhatian dari negara G20 nanti, bagaimana investasi lebih besar lagi terhadap tuberkulosis.
I want to call all the G20 countries to further increase funding related to the infectious disease.
We all hope for a vaccine, for an effective working vaccine. And this is something that has to happen very soon.
My message to G20 leaders is to please invest in TB. Invest in new vaccines. Please invest in new diagnostics. Please invest in new drugs, ones that are not toxic and ones that don't make the lives of our people a living hell. I request you, world leaders, to please invest in TB today, because only if you do so can we hold on to any hope of ending TB by 2030. Thank you.
Thank you very much, ladies and gentlemen. All participants and delegates right now may exit the room. Thank you very much. Once again, all delegates and participants, thank you for your participations. And now all delegates and participants may exit the room. Thank you.